Okay, we are starting. This is
we already have crossed 50 participants, so we can start now.
So the topic of today's panel discussion will be decision making in ACL surgery. So this is the greatest knowledge heist in the lockdown, and our panelists are Dr. Sudeep Manbaide, Dr. Amit Joshi, Dr. Naveen Khan, Dr. Rajiv, and myself will be the moderator. And we will be live in Zoom. So let us start with the timeline of ACL injury and its treatment. ACL injury basically started from the good understanding of ACL injury started from 1960s, when the anterior draw test was described. At that time, the treatment of ACL injury used to be the cast for about 2 to 3 months, and the stiff knee resulting afterwards was blessing in disguise for these ACL injuries. Later on, 1970s, the Lachman test and pivot shift test were discovered, and accordingly, extra-articular procedures and open reconstruction of ACL was described. And in about 1980s to 2000, there was significant advancement of arthroscopy, thus leading to arthroscopic ACL reconstruction, and there was introduction of good grafts for ACL reconstruction. And after about 2000, there was introduction of various concepts like double bundle, remnant preservation, and nowadays we are again combining those extra-articular procedures with ACL reconstruction, and we are now doing again the ACL repairs. So with this background, as we all know, ACL injury is diagnosed with history and various tests of instability and with MRI findings. So talking about history, I would like to ask Naveen sir. Naveen sir, are you there, sir? Naveen sir. Hello?
Yes, yes. Are you listening me?
Yes, sir. Yes, sir.
Yes, okay.
So my question is, while diagnosing a case of ACL injury, what are the various history points in history that you would like to elicit in a case of suspected ACL injury, sir?
Yeah, nowadays the commonly used criteria is a limp index that we commonly follow. That the sustaining after the injury, we know actually want to know what is the mechanism of injury, what was the mode of injury by which he got the injury. Besides that, the LIMP, the things that whether the leg was giving way at the time of injury, he was unable to continue with that particular game. There's a massive swelling was there or not, or the pop sound heard. So out of these 4 criteria, if there is more than 2, then that way we suspect the probably ACL injury is there.
So absolutely, sir. As Naveen sir has mentioned, the limp index or LIMP, L stands for leg giving away, I for immediate swelling, M for massive inability to continue activity, M for massive swelling, and P for pop out. These are not the new things. These are very old things described in literature as typical history, but Colin Eyre et al. In 2017 summarized them in an acronym called limp index. So according to them, if 2 out of 4 limp index features are positive, then there is high probability that patient has ACL injury. These has been discussed in last class, so I'm going fast in this limp index. So let's go on to a case. I would like to ask Sudeep sir to take this case. Sudeep sir.
Okay, yes.
So let us have a.
Let me change the orientation. Okay, can you see me? Because
yes,
okay.
Yes, sir.
Yeah. That okay.
So 25 years old male. He has twisting injury 2 days back while playing football. The limp index was 3/4. On examination, there was swelling. The swelling was significant, and the range of motion was very painful, and he cannot weight bear. And X-ray was done at some center. X-ray was normal. So what would you like to do in this case? The 2 days old, very active individual, 21 individual.
Dr. Vivek, thank you for this case. Definitely 2 days history. If possible, I'll try to elicit. I'll try to take the detailed history and take the limp index.
Yes,
and
sir.
I'll try. Hello.
Limp index is 3/4, sir.
3/4. Okay.
Yes, sir.
Then I'll try to elicit some of the sign like anterior draw sign A Lachman test definitely I have to do, and if possible, clinically possible, I'll do pivot shift test if patient allows.
Okay. Do you think that the pivot shift test and various tests can be elicited, even Lachman test can be elicited in acute setting like 2 days? This is very acute case. Sudhir
No,
sir?
it's not possible. Definitely not possible in initial cases. But there are some cooperative patients. Sometime they do cooperate. If they do not, then I just give them a brace for a few days. Start just quadricep exercise, and again I like to assess them after very short period. Within a week, I would like to assess the patient again.
Rajiv sir, what are the tests that you do in acute need, special case? Those who have joined just now in our meeting, please mute their audio.
Okay. So in a 25-year-old male with a twisting injury 2 days back while playing football with a limb index of 3/4, there's swelling on examination, ROM is painful. So I would definitely do a Lachman test. I would do a Lachman test, and if I would try and palpate the medial joint line, the lateral joint, do a gentle palpation. And I think the only test that I would be able to do well is probably a Lachman test.
Okay, sir. So Lachman test, I think all of other panelists also agree that if we are gentle enough, Lachman test can be done in acute knee conditions. I would like to ask Amit sir, I have mentioned 5 tests for ACL in my presentation. Out of these 5 tests, what are your workhorse for diagnosis of ACL injury, sir? Maybe it is acute or chronic injury. Amit sir.
Let me start with little earlier. The previous question was how you proceed, which test. So first thing I do is the active and the passive range of motion of the patient, of the affected knee. So if you do active as well as the passive knee range of motion, this will give you an idea how much the patient is having pain. So what are the tests you are going to elicit in that patient? Suppose if someone is having good 90-degree, you can think of eliciting some other tests also. If it is painless, then you can do some other test also. But if the range of motion is just limited to 5 to 10 degree, it was severely painful, probably certain clinical examination is going to be limited in this particular case. So I'll tailor, actually what I wanted to emphasize that I will tailor my clinical examination of that particular patient based upon how much the pain the patient is having and how much is the range of motion the patient is having. So based upon that, and I absolutely agree with Rajiv that Lachman test is my first test that I do. If there are no collateral injuries, no bruises, probably I'll go ahead with the palpation of the medial and the lateral joint line as well. But for ACL per se, Lachman is my workhorse in 2 days time.
Okay, sir. If imagine if this case is 3 months old or 6 months old, then what are the tests among these 5 tests I have shown here? What are your workhorse for diagnosis of ACL injury in your clinical practice?
If it is 3 months old, the joint is very supple. Probably I'll perform all the tests except except the Lely's test, because I'm not good at performing the Lely's test. So I will not perform a Lely's test. Otherwise, Lachman test, anterior drawer, posterior drawer, pivot shift test, Slocum test, and some tests for patella that you're missing. I'll definitely do certain tests for patella, and then certain tests for meniscus also.
So I think all the panelists must have, I think they all agree that out of these 5 tests, except for the Lely test, all 4 tests should be done. And basically the Lachman test and pivot shift test are very important tests. So I have sorted out some questions in Lachman test and pivot shift test. I would like to ask Rajiv sir. Sir, Lachman test, there are 2 things, endpoint or translation. So what is more important? We have more than endpoint. Why, sir?
Yes. Because see, you can have a lax knee, but the ACL can still be intact.
Okay.
So the endpoint will tell you whether
any reason, sir? Having lax
hyperlaxity,
okay.
Hyperlaxity with a high Beaton score, maybe a partial tear. So an endpoint which is firm says there's an intact ACL, but an endpoint which is soft says that the ACL is torn.
So this, this must be very clear. The concept must be very clear. Lachman test has two components, the endpoint and translation, and endpoint is the most important because the pulse, the translation may be increased in patients with hyperligamentous laxity and with partial tears. Sir, if the patient has the small hands like ladies, so what are the various variations of Lachman test? Rajiv sir.
So see, you have various variations of the Lachman test. You have something which is known as a ladies Lachman's test.
Okay,
So
sir.
you place your thigh under the patient's knee. Okay, I wish I could demonstrate that to you. You place your thigh, your patient is lying on the bed. If it's the right knee, you fold your thigh, put it under the patient's thigh, and you stabilize with your left hand. With your left hand, you stabilize the thigh on the patient's thigh on your thigh, and with the right hand, you do your anterior translation. So when you have small hands also with one hand, because sometimes you may not be able to grip the thigh.
Yes,
that
exactly.
is one variation.
Yes.
The second variation is you could have the knee off the table. Okay, so off the table with your left hand, you stabilize the thigh again off the table, and with the right hand, you assess your translation. You can do something which is known as a prone Lachman's.
Yes, sir.
So you could have the patient prone and do a prone Lachman's also. So there are various variations. This is what I can think of at the moment.
Yes, sir. There are three main variations, and they are done for very heavy patients or when the doctor himself has very small hands. So that normally Lachman test is very difficult to do. So I would like to ask Naveen sir, how common is in your practice the pivot shift test? Naveen sir.
For the pivot shift, rarely I can do in my OPDs.
Okay.
The patient is very relaxed and very long, as we say, maybe 3 months or later on, if patient cooperate with me, then only pivot shift is elicitable for me. But usually in routine OT, when I go for surgery, then after anesthesia, almost all the cases I try to elicit, and many of it I could find positive pivot.
Any reason, sir? Almost every cases you want to do pivot shift test. Any reason, sir? Because we have already diagnosed with Lachman test. Why to do pivot shift test?
Yeah, after Lachman test is basically for the anterior-posterior instability. Yes, and pivot shift is one of the very important component about the rotation. Okay. So if I find a grade 3 pivot shift while doing, then my plan is not only ACL reconstruction, I also would like to go ahead with the lateral extraarticular tenodesis in those cases, if grade 3 pivot is there. If it is just anterior-posterior translation, Lachman is there, pivot is maybe 1 or 2, then I might just go ahead with the ACL reconstruction only.
Sudeep sir, would you like to add something, sir? Why would you like to do pivot shift test in every cases?
I would little differ from Naveen, because in his initial days I used to do much less of the pivot shift test, but with the passing time, I have tried to elicit whenever there is a history of giving way or instability. I always try to elicit this test, and particularly male ETC, with the patient is relaxed, they are cooperative. I'm able to, elicit the test in OPD setup also, and many times, particularly if the patients are cooperative.
Sir, how important is this test to be elicited in OPD, or this has to be reserved in OT?
Definitely important, because this will definitely give me a criteria to decide whether this patient requires ACL reconstruction or not.
How, sir?
Because it shows that it shows the instability.
Okay, sir.
The instability is the main cause of ACL reconstruction than the pain.
Amit sir, would you like to add something? Because this test is very important clinically. That's why I want to stick some more time with this test.
I absolutely agree with all the panelists that pivot shift test I do pre-op, I do intra-op as well, and then I do it in the follow-ups. So my pivot shift test is very, very workhorse, especially for those who wants to manage their ACL conservatively. So if a patient who wants to manage conservatively, but if it is pivot shift test positive, which indicates that there is a functional instability of the patient. So in that case, I'll not suggest that patient to try a conservative management. I'll definitely say that surgical management will be a better option for him, because chances of secondary injury.
So
Intraoperatively,
pivot shift, positive pivot shift decides something else like adding something extra articularly as well, or pivot shift
That
is just
also,
to elicit the instability, sir?
I agree. Explosive pivot shift test, that means a grade 4 pivot shift test. A lot of
Yes.
authors, they say that probably in those cases, ALL reconstruction either by a true ALL or the extra articular tenodesis, lateral LET, lateral extra articular tenodesis, has to be supplemented. But it is not only the that thing. The grade of pivot shift will decide either to supplement other extra procedure. There are so many other factors also involved in decision making. But what I mean to say that pivot shift test will be very, very essential to decide which patient can be managed conservatively or which should not be managed conservatively. Actually, it has to be done under anesthesia, but over my last few years practice, I can see that a gentle internal rotation pivot shift test can be done almost in
Okay.
95% of the patient, even in OPD. Intraoperatively, I do in 2 times, one before surgery under anesthesia. That will also give us a real pivot shift test.
Okay.
One after surgery, it is controversial, but a gentle pivot shift test after surgery is very, very essential to do, though it is debatable, but it will tell us that either we need to supplement with some extra articular procedure to protect that ACL. If after reconstruction also, there
Yes.
is a pivot shift test positive. And then
Excellent. Okay.
third thing is in follow-up period also, if some patient comes with instability, giving way such features even after the ACL reconstruction, if you can elicit a pivot shift test, and the literature have suggested that those patients who have pivot shift test positive after the surgery as well, there is a higher chance that this patient will require a revision surgery. So
Okay.
I do pre-op, intra-op, as well as post-op.
Final quick questions to Rajiv, sir. Sir, when do you do pivot shift tests? Intra-op or pre-op?
I think I agree with Amit. In the OPD, mostly not, unless it's a very cold case.
Mhm.
Otherwise, pre-op, intra-op, and post-op is very, very important.
So I
He has
think,
already mentioned, I think.
yes, I think this is very important message to all of the participants that Lachman test is very important test. This is workup for diagnosis, but pivot shift test is the test that gives absolute degree of us knowledge about the degree of instability. So pivot shift test must be done, or it should be tried in OPD to be elicited. If pivot shift test is positive, then that patient is going to be non-cooperate, but that patient is going to be benefited from the ACL surgery. Okay, so I would like, so my next question, excuse me.
Your next question is investigation. Which one to do?
Yes, sir. I'm having call, Facebook call, so I'm canceling it.
You are a busy guy.
Yeah. So my next question is to Sudip sir. Sir. This is what are these investigations that you want to do in case of ACL injury, sir?
Definitely, after X-ray has been done, X-ray is a must for the initial injury. After that, if I am clinically suspecting the ACL injury, definitely next my investigation is going to be MRI, because
Sir,
that is going to
X-ray,
give you.
how important is X-ray, sir? Acute knee injury, X-rays are okay, they are important. So patient came to you after about 5 months. Clinically, they have ACL torn. So would you still want to do X-ray or not?
After 5 minutes, definitely, because I would like to see if there is any other changes, at least one for my record. Other things there can be some diagnostic factor like Seagon fractures, which was missed in initial days. That can be found out. And sometime even the osteochondral lesions, sometimes like tunnel views are very important. So definitely X-rays are important even if they come late.
So X-ray must be done. Even they come late. Then when do you advise MRI, sir?
MRI, whenever I'm suspecting ACL injury, as soon as possible.
Okay, as soon as
Maybe sometime within a week, or
okay.
sometime maybe 2 weeks.
Okay, sir.
Depends when the patient comes.
This has been discussed in past last lecture as well, last panel discussion as well. The X-ray and MRI should not investigate.
Vivek, can I add just a little?
Yes, sir.
Vivek, just I can add on X-ray, that X-ray is very, very essential in acute cases as well as in the chronic cases as well. In chronic case, I would love to see the arthritis. It's just not the plain AP and lateral view. Probably I'll do a PA notch view so that I'll see the PA view. Especially I'll see the osteoarthritis of the tibiofemoral joint, and then I'll definitely look at the patellofemoral joint as well, because it is very, very essential to grade the osteoarthritis. If there is a higher grade of the osteoarthritis, merely performing a constraining surgery like ACL reconstruction may rather worsen the situation. So that is why ACL, especially weight-bearing ACL, also to see the alignment of the knee. So for these things, we have been neglecting X-ray of late also, in assessment of ACL tear. So in chronic cases, rather than all those acute features, it's important to see the osteoarthritis.
Sir, can I summarize from your explanation that the osteoarthritic knees are contraindications for ACL surgery?
It is not contraindication. Certain degree of osteoarthritis, if it is a young case, probably you supplement along with the ACL. Maybe the patient will require a high tibial osteotomy or some other kind of surgery. It is not contraindication, but knowing the status of arthritis, knowing the status of the alignment in X-ray is essential before attempting a ACL. I'd love to know what Rajiv says and what our chairman has opinion on it. Please.
Can I say something?
Yes, sir. Yes, sir. Please, sir.
Yeah, so absolutely, Amit, I go with you 100% that when you do an X-ray, yes, besides all the other things like that Sagon sign and that natural notch, deep sign, all that, besides that, you must look at alignment. See, because when a patient especially comes with pain, if a patient comes with instability, okay, good, then it's only because of the ACL. But if a patient complains of pain, then we must look at osteoarthritis and we must get standing views, because a lot of times, when the patient complains of pain and has instability, we may need to correct the alignment also, which will be a whole package.
Yes, sir.
So I think that's what Amit was trying to say. That's all I wanted to add. Absolutely. Yeah, that's it.
Okay.
Sometimes one point I want to add.
Okay.
Sometimes the graft choice is bone, tendon, bone.
Okay.
For those cases,
yes,
if there's a patella alta or patella baja, you have to take care of that also. Besides osteoarthritis and alignment, I want to add that.
So, in ACL injury cases, if you are planning for surgery, then X-ray is must. X-ray is must to see whether there is osteoarthritic changes. X-ray is must to see the alignment. X-ray is must to see whether patella is patella baja or patella alta. Yes. And is there any signs of avulsion injury, right? I think these are the questions of our discussion. Yes. So, I would like to continue with Rajiv, sir. When would you like to do ACL surgery in this case? He is 25 years, active, and there is 2 days history, and the patient has severe pain. He cannot bend his knees. Extension is not good.
Okay. So first of all, I would try and do a Lachman's test. Will that come out? It'll come out to be positive, right, Vivek? It'll come out to be positive. Yes. Then I will send the patient for an MRI. And in the meanwhile,
sir, ACL tear has been diagnosed, isolated ACL.
Okay.
2 days old, 25 years, active, and patient has severe pain.
Okay. So now I will send the patient for cryotherapy, basically icing of the knee. So he will ice his knee and he will rest his knee. I will apply a brace for a few days till his swelling subsides. Then after I will prescribe him NSAIDs or any anti-inflammatories along with a proton pump inhibitor, ask him to rest his knee. After a few days, when his swelling subsides a little bit, I will start prehab. There's a lot of noise.
I would like to request our participants to mute their audio, please. Please mute your audio. It's
So
quite disturbing.
yeah, so I will ice the knee and start prehab for the ACL. So where a physiotherapist will work on him, they will do icing, they will teach him isometric quads, they will start knee bending exercises very gently. I am talking about an isolated ACL injury.
Okay, sir. Is there
Okay,
any
and
time duration that
hello.
we will do surgery? We won't touch this ACL. Uh, is there any time?
There's so much of noise here. There's so much of noise
Lot of
here.
noise actually.
तुफान
Yeah.
तुफानलाई भन त एकचोटि तुफानजी हुनुहुन्छ अनम्युट भएको मेबी has done someone here. Yeah.
Yeah.
And Dr. Robbie also, I think.
Robbie को पनि Robbie, hello Robbie.
Please mute.
Robbie को mute छ.
Who is this? Making so much noise.
Pura family.
Okay, anyway, it's good now. It's good now.
Okay.
Okay. So I was saying that I'm going to ice the knee, and then we will do a prehab. We'll do a prehab for the ACL. And what are we waiting for? We are waiting for a quiet knee. So once the swelling subsides and the patient is able to bend his knee up to about 120 degrees, then I think that is the correct time to go for an ACL.
Amit sir, any addition?
I absolutely agree, but my parameters of taking the patient to operation is not only the flexion to 100 degrees, but it is important is active extension up to 0 degree.
Okay.
So
Yes,
until
active at 0 to 120.
Yes, maybe active.
Yes.
If someone who is having active extension and someone who is having SLR positive, that means can do SLR, that means his quads is already more than 70% strong. So probably in these cases I'll take. Usually it is about 7 to 2 weeks time.
Sudeep sir, you'll wait or take for surgery straight away in this case?
No, I'll definitely wait for till the knee becomes relatively quiet
Okay.
and range of movement at least 110 and 120 degree. And I would again like to re-emphasize the point where Rajiv has said, because many times why I want to stress on this point is many times we get a patients from our seen by many of our orthopedic colleagues, and this pre-operative rehab or simple isometric quadricep exercise are not being taught to the patient. By the time they really even come within 2 weeks, they really have started having quadricep wasting. So I think many times, I think you also must have seen this, and this point has to emphasize, even if you are not doing this surgery or you have to decide, but this pre-operative rehabilitation is very, very important point. So many times we have seen within 2 weeks or 3 weeks, they come with a lot of wasting. They have just put into the braces and they have not been advised these exercises.
So Sudeep sir, what is
Yes.
in your experience, in your clinical experience, how early have you taken the case for surgery?
I think not before 4 weeks.
Okay, sir. In
Most of
any
the time, I
condition,
wait for
what are the conditions when you take those cases very early?
condition early. Suppose if there is a osteochondral lesions are there, then definitely that is early surgery required. If there is a entrapped meniscus is there, which is causing not allowing the patient to move the knee, and even it is a knee really painful. These are the only few conditions I think we have to take the patient for early surgery. Isolated
Any difference
ACL.
of opinion, sir? Navin sir? Navin sir? Okay, I think he's not there. So all this concept of delayed surgery has come from the fear of the condition called arthrofibrosis. And it has been shown by the paper by Selvon that arthrofibrosis is very, very common if the knee is intervened very early in early stages. But the thing is, this was published in 1991 when the fixation modalities were not very strong, and post-operative rehab was not very aggressive, and this was case retrospective study of 169 cases only. So nowadays there are multiple studies that has shown that early cases, early intervention ACL reconstruction in acute knee injuries also are not associated with a significant increase in risk of arthrofibrosis. And early and delayed intervention is very, very controversial. It depends upon various studies. Some say it is as early as possible, some say it is 2 weeks, or some say it is 10 weeks. So it is very controversial thing. But what our panelists has agreed, I think, is the main cause of arthrophyrosis is not the time duration, but the irritable knee. The irritable knee is preoperative irritation, operative limited range of motion, and preoperative pain. The limited extension and limited flexion, along with the swelling and pain is there, then that knee is angry knee. So we should not intervene those knee. In those cases, I think the silence is the best answer. So we have to wait till the knee is silent in case of isolated ACL tear. So Sudeep sir, ACL injury may be occurred in various individuals. So I have given you 3 pictures. One is the young lad with very obese build. Second picture has 3 old guys running, very active. And third one is middle-aged individual doing manual labor. If ACL injury, isolated ACL injury is there in all these 3 groups, whom would you prescribe ACL injury and whom you would not?
Actually, I will not go with the age of the patient. It depends upon their activity level. A person who is even at the 60 years old, but he is physically very, very active, and if he has an ACL injury and he doesn't have other features of osteoarthritis, and he wants to go back to his active life, like what you have shown, your old people, they are running, they may be around 60, 65. Even those cases, if you have ACL injury and they have instability, I would like to go for it. Second features you have shown is that the person who is carrying a load, definitely he will require a ACL reconstruction because of this activity level. And the guy who is obese guy, it depends. His, I mean, not only with the MRI or investigation finding.
Okay.
What is his clinical? Clinical finding is, and what is his expectation?
So he stays like this for whole day.
Definitely, he cannot stay like this a whole day. But if he's finding instability and if he's coming in the way of his day-to-day living activity, his unstable knee, definitely he will also require a ACL reconstruction. Even if because there is nothing like copers or non-copers, because he may have to walk, he may have to go downstairs, he may have to run sometime.
Okay.
So it depends on his need at this time.
Amit sir, out of these 3 patients, whom would you advise ACL surgery?
It's not, I don't look at the patient shape, size, age, and all these things. It's the functional demand. Either the patient is having features of instability, but the outcome of all these phases will be different. If it is obese, if obese, the chances of failure in obese patient is high. So these pictures I'll take consideration not in deciding either I need to do ACL or not. I'll take instability, but this picture I'll take in consideration to counsel the patient. What are the chances of failure? What are the grafts you are going to get? From where you are going to get? What are the modifications you have to make in your life? These are the things I'll make changes from your pictures.
I would like to change my question a little. For example, if out of all these 3 groups, they say we are not ready for surgery. So in whom you would stress more for surgery, and in which group you would like to say, okay, no surgery, okay?
It's rather than readiness, it's important to counsel the patient who requires surgery or not. Probably obese patient, if he wants to do a sedentary lifestyle and he is not having features of instability or limitation of activities in both these obese and the older people, they are managing their activities with the deficient knee, I can manage them conservatively. But this young guy who is a laborer and then carrying that kind of weight, and then I can see a beautiful terrain, heavy terrain, probably even if he doesn't say he wants to manage conservatively, this is the patient who is at high risk of having secondary injury, and probably I'll decide a surgery will be beneficial for you.
Rajiv sir, would you like to advise or offer surgery for these old guys with ACL injury?
For these old guys, now Vivek, the previous question that you asked regarding the 3 people, right?
Yes.
I think the person who's carrying the doko and with the Nepali background, that guy will agree to do it with me. The other 2 won't. Okay,
Yes, sir.
because one guy looks like a maybe a Thai or a Korean or a Chinese guy. The other guys are from France, so it may not be easy to convince them. Okay, now the thing is that obese guy, I think he needs a physician more than an ACL because soon he's not going to need an ACL. If he's going to sit whole day and eat pizza, why should we do his ACL?
Okay. Okay.
Like you were saying. Okay,
That was my
but
question.
yeah. But the question that you asked me about these old guys, right?
Yes,
These
sir.
old guys. Now, the thing is, see, the thing is, after this old man or the elderly gentleman has had an ACL injury, it's not only the age factor.
Mm-hmm.
We know that age is not a factor that we
Mhm.
consider. So we need to talk to the patient. It's very, very important to talk to the patient. We must find out whether he has any episodes of giving way, whether he has any instability. We must ask him whether he's going to pursue the same sports or not. So if
Okay.
he's going to say, okay, I've injured my ACL, I'm an elderly man, I am not going to go undergo further sports, then we don't need to do his ACL without any instability. Okay, for him to continue his daily life pursuits in France.
Mm-hmm.
Okay, maybe that's different in Nepal.
Okay, sir.
Okay, because of a hilly terrain, maybe things are different. And before doing his ACL, even if he had instability, we must consider taking, like we were talking about, his X-rays, his MRI. We make him do standing views, look at the varus in his knees, and after that, then maybe we could come to a conclusion whether we need to do his ACL or not.
So
So
I
more
think
than just saying, yeah.
I think we can just conclude that age is just a number. It is the physiological
Age is just a number, absolutely.
But
Age
Yes.
is
important
physiology.
number,
Yes,
just a
sir.
number, but
Yes.
important number.
Now,
Yes.
yeah, if you
It
have
is
a patient with
physiological age
florid
that is more important,
osteoarthritis,
right?
yeah, then it's no point. Yeah,
It is the
that's pretty
physiological
true.
age of the patient that is more important than the chronological
Yeah,
age.
maybe. Yeah,
I
you
would
could say
say.
that. Okay, you could
Okay.
say that.
Because
Yeah.
there are people who have climbed Mount Everest over 70s.
Yes,
So
sir.
Yeah.
age is definitely.
So
Yeah.
this
Yes.
is the video of that patient, the first patient I was mentioning to you, 25 years old, 2 days old history. We took him after the knee became silent, and this was his arthroscopic picture. Rajiv sir, uh,
Mhm.
the ACL stump looks very good. I think it is
This is the left knee. This is
uh,
the left knee.
okay, left knee. And this is type
Left
1
knee.
ACL injury. So would you like to think about repair of this ACL?
Absolutely. This is gone
Okay.
from the femoral attachment, as far as I can see.
Okay.
Is that true, Vivek? I think it's
Yes,
torn
yes.
from the femoral
Yes,
attachment.
yes,
Yeah.
sir.
So this is a good case of repair now, because he's a young patient,
Uh-huh.
okay, and he's got a femoral avulsion. So
Uh-huh.
you could go in and you could repair his ACL.
Okay. Any difference in opinion? So repair or reconstruct?
Sorry, are you asking me?
Yes, sir. Repair or reconstruct in this case, sir?
I have not done the repair so far. So maybe I'll go for reconstruction. It's technically, I have not done repair so far.
Okay. Naveen, sir?
The repair has become nowadays very popular, but the enough data still is not there for me to convince for repair. So I'll go with ACL reconstruction with preserving the remnant.
Remnants. Okay. It's Amit, sir. Would you like to tell something?
I absolutely agree with Nabeen that repairing all cases at this moment doesn't have a good evidence for practice, and then the complications of repair have been shown to be quite obvious nowadays because of re-rupture, including the cyclops lesion, non-healing, and all these kind of things. So um, uh, our protocol is repair only in those cases when there is little bit of bone chunk is there. In this case, I'll do a repair as well as augmentation with the hamstring graft. So it will be kind of a repair, means it will be kind of a remnant preservation. I'll try to preserve everything and do a ACL reconstruction at the same time.
I have seen many repairs being performed by you while with you, sir. So are there? I think it would be good to the listeners if you share some of your knowledge about the repair, sir, your experience about the repair. When do we repair? When not repair in this type of scenarios?
It depends upon so many things. Number one is the patient factor. So what is the functional demand of the patient? What he wants? If it is really a sports person, probably repair alone is not going to help him out. The patient factor is there. Second one is the the type of the ACL tear is very, very important. So from MRI itself, it was visible that this was a type 1, and
Yes.
we are coming up with our own classification in which we have seen quite a few femoral avulsion, femoral bony avulsion. So when you have bony pieces in your end of your ACL, probably they nicely incorporate and just repair will work. But when you do this type of soft tissue avulsion, if you do a soft tissue avulsion repair only, it has to attach to the bony surface, which is not that easy for a tissue to attach into the bony surface, because it is not going, you know that from ACL reconstruction experience, we all know that the ACL heals at the aperture. So since there is no aperture, it's very difficult for these tissues to heal, since it is intra-articular on top of that, since heal to the femoral condyles. So that is why in these cases, probably repairing it along with the augmentation with the autograft. Many people augment with the tape and other fibers and so many things, but we have learned that probably in these cases, repair will become a wider horizon of a remnant preservation, along with the small 7 or 6.5 or 7.5 hamstring graft that will be.
So I think we can conclude that if we get these type of stumps during our arthroscopy, so we can try repair, but when there is complete soft tissue tear, then only repair is never going to do it work. So
as of now, we know that Difelis is doing it in the very regular basis, but if you read a recent arthroscopy journal, even in 2020 February issue, there is an editorial which says that this is a good technique, probably has various advantages, but this is not that everybody should venture upon it, and we have limited data on recommending repair as a regular basis.
So in this time also, the reconstruction is the gold standard, not the repair. And if repair is repair needs higher expertise, so that's why if we want to do something in this case, reconstruction with remnant preservation is the best one, right, sir?
Correct.
Okay, so Nagmani, I think we have finished the first case. Is there any questions regarding the first case?
That's going amazing. I would commend it, Vivek, because there are plenty of questions which are being asked.
Okay.
How do you want the questions to be asked? Would you want the participants to come on for a quick moment and ask the question, or
you ask questions on their behalf?
Okay. So there was this first question which was asked to the panelist by Dr. Sunil Panta. He asked whether for Latchman test, how important is it to keep the limb in slight external rotation? Now it's on your board, Vivek. You can ask any of the panelists or chair or co-chair regarding the opinion.
Rajiv, sir.
Yeah, I think it's important to keep the limb in external rotation because the knee is very lax in external rotation. Okay, and you're standing on the outer side of the patient. So it's easy to put it in slight external rotation. So you let the external rotation happens at the hip joint, right? So the hip joint is slight, relaxed external rotation. I think that's a good point. I think I would do my Latchman in slight external rotation.
Ishwar, sir, can you add something, sir? Will you unmute your mic and answer this question? Ishwar, sir.
It's a good point. You can externally rotate the limb and do your test, but the main thing is you have to make the patient relaxed, and so that you can do your Lachman test more properly. It's kind of more getting the confidence of the patient in yourself and doing the test. And of course, all these tests are to be practiced very frequently so that you get the confidence and you feel the test. How positive it can be.
Well, sorry to interrupt, but we will elaborate a little bit. How does external rotation help in Latchman, sir? Because this question has been posted, but we talked about relaxation and all, but does external rotation of your limb during Latchman help you with anything, or is it just that you feel that it's easy to do?
Yeah, that is what I mean. You need, I actually don't know, like if external rotation is that much of a contributing factor to your getting a positive Lachman, but it's your confidence and getting the confidence of the patient to do the test properly.
Can I add a little bit that
yes,
actually if you see the normal position, relaxed position of the leg, The relaxed position of the lower limb is in external rotation.
In external rotation.
So yes, in external rotation. If you
Yeah,
try
so it's
the patient either actively or passively internally rotate or put it into the neutral position, there is some degree of contraction of the muscle coming to the place, especially internal rotators, femur, especially hamstring, which will pull the tibia internal rotated. So probably it's wise doing enlargement test in 10 to 15 degree of external rotation when it is most relaxed position of the
Fair enough. Vivek,
Okay,
should I move
can
with
you
the
go to
second
next
question?
question?
Yeah,
Can I add one point to this?
Yes, sir. Please go on, sir.
Yeah, particularly if you are examining the patient about the external rotation, the limb has to be close to the the surgeon. If the limb is on the other side, maybe it becomes difficult. So
it's
always
not
you have to
possible.
change the side of the
Yeah,
patients.
yeah, absolutely. You
Yes,
shouldn't
yes,
do
yes,
the other leg
Yes, yes.
Lachman test from the other side. You're right.
yes.
That's the side. Yeah.
Agmani, can we have another question?
yeah, yeah. The
We
second question was
will
from
do the questions.
Dr.
Yeah.
Shravan Kumar Thapa
Hmm.
from Chitwan. He asked whether there is any role of proximal fibular osteotomy for early OA in young 35 to 45 years old individual with ACL injury along with simultaneous ACL reconstruction.
Okay. I
If it's
will give
a
you these
yeah.
questions to Amit, sir.
A
Proximal fibular
35-year-old
osteotomy
gentleman.
along with ACL.
Yeah, in 35-year-old gentlemen, rather than proximal fibular osteotomy, if there is a arthritis, there is a malalignment of the knee joint, I'll choose high tibial osteotomy rather than the proximal fibular osteotomy. The case is different if it is about 50-year-old gentleman. There is a medial isolated medial condyle osteoarthritis. In that case, you can manage as a part of treatment of osteoarthritis. But
Okay.
if it is part of treatment of ACL tear, then probably high tibial osteotomy is a better option than the
Any
proximal
of
fibular.
our panelists and senior sirs doing PFO regularly? I think Sudeep
No,
sir.
no,
No.
No,
Rajiv sir, no.
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 Naveen sir, do you do PFO regularly?
No.
For
No.
ACL tear,
No. For osteoarthritis.
No.
No.
we have been doing it. You know that we have been doing it
Yes.
not regularly, but for those patients who refuse to undergo total knee replacement or that thing, but not for the young patient and not with the ACL tear.
So I think we can conclude PFO definitely a big no for 35 years for the alignment issue. But if it is more than 45 or 50, there is controversial. PFO itself is a controversial surgery. STO is the time tested surgery. PFO is not. Okay. Another question. Last question, I think.
Yeah.
Nagmani?
Let's make it second last, Dr. Vivek, because there are
Okay.
two. One the next one is by Dr. Roshan Kalwar, and it was similar kind of question asked by Amit sir also. If knee ROM does not improve satisfactorily in prehab, so what would be your plan? What would be your plan with the patient with LCL?
So
And I
prehab
would
was
suggest
very
Dr. Vivek get Arjun sir also. Arjun sir is, I don't know,
okay.
he's not
Okay.
interacting, so you get him also involved on the scene.
So we asked for prehab and it's not improved. Arjun sir, would you like to answer, sir? Arjun sir, please unmute your mic. Okay, I think he's busy with something else. Rajiv sir, would you
Can I
like to
answer?
answer this question, sir?
Okay, Rajiv, please, Rajiv, go ahead.
If you what is the question? Sorry, Vivek. If you do prehab and it doesn't.
Acute knee injury, you ask for prehab.
Yes.
The patient has done prehab for about 1 week, not improved, as you expect.
The patient has done prehab for 1 week and he hasn't improved.
Yes, sir.
He is not better at all.
He has improved a bit, but full extension is not achieved. The range of motion is still 80.
So the thing is basically, see, we have to continue with prehab for a longer time. So how long? Let's see, if I did prehab for 3 weeks, he still doesn't improve. I'm yet to see a patient like that.
Okay.
The thing is, you go on doing prehab and the patient's ROM doesn't increase. Is that the question?
Yeah, I think that was the question.
No, but why does the patient's ROM does not increase?
So would you like you'd like to see the patient again?
Yeah, I would like to see the patient again, because this is, I mean, why is the patient not improving? That's the question. Because see, patients will improve. Some may take, I don't follow any calendar. It's not like 1 week and then I will do surgery. I will wait till the patient's knee becomes 120 degrees. If it doesn't, then they have to find out why it hasn't become like that. Then maybe proceed
any
from
reason
there.
that the patient not improving, sir, in a mind?
Maybe he's got a bucket handle tear, which is not allowing full extension. Maybe he's got osteochondral injuries, or things like that. Maybe it's because of the bony contusions that he's got a lot of subcutaneous edema, and the bony contusions where he's going to take time for his knee to settle down. Because all ACLs don't happen the same way. Like previously, a question was asked: in how many days have you done an ACL? I have done certain ACLs very early, even 5 days, because this lady just got off a bus and twisted her knee. And she hardly had anything. She had full range of motion when she came. I was a little confused whether the ACL injury happened earlier.
Okay.
So it depends on the quiet knee.
Okay.
I don't know. Amit, can you answer that? I don't know.
I absolutely agree.
Yeah.
Arjunda, you want to answer? Please go ahead.
Yeah.
Yeah. Okay. Dr. Vivek,
Yes,
I
sir.
agree with Dr. Manandar. Okay, Rajiv. Okay. Because it's a thought block. Okay.
Sounds like different, Manandar.
I'd like to see the patient, because there are various causes of restriction of range of movement. Since you have examined, if the patient knee is silent, it is not reactive, there is no effusion, the surrounding soft tissue is also okay, then we should look for the interarticular structures that can cause the restriction of movement also. And so that I would like to again review the MRI. If MRI has not been done, again asked to do the MRI. If
You can manage
Sorry for technical.
it also, because you have seen ACL is intact. You have seen ACL is intact, and then you have followed that patient up. No re-injuries, nothing has happened. So there is no point doing a
Naveen sir,
lateral
any
testing
different
until
views?
unless
Naveen
patient
sir,
complains of something. There is no point doing lateral testing.
any different views, Naveen sir?
Before
Don't worry, Vivek, I had covered
Okay, thank you so much.
your back. I had your back when you were
Before
on.
answering this question,
Naveen sir.
answering this question, I would like to the answer of the previous question, that even of the adequate rehabilitation have done range of motion. So the common causes, what probably I have observed in couple of cases, is sometimes the ACL going to the intercondylar node that restrict the extension. Number one. Number two, a big osteophyte in the intercondylar nodes that also sometimes restricts the extension. And the third, sometimes there is a contraction of the posterior capsule that also doesn't allow. So for those cases, you have to go proceed for the surgery and correct adequately. For the answer of the first question. Now regarding the Latchman, there are, as Amit has said, the various studies have said that even you just do immediate after post-op only, if you are doing the Latchman test, you are giving a lot of strain in the rotator cruciate ligament. One of the study done by, if you see, a lot of noise is coming. Yeah, that the if you are doing.
Dr. Devendra, please mute your Zoom. Dr. Devendra Acharya.
So even
yes, sir. Please carry on.
If you are in a post-op period, then you are putting too much of a strain. So immediately in post-op also, practically, if you just keep your hand on your heart, if all of us are doing Latchman post-op, you are doing the very soft hand. Probably almost all of us with a hamstring graft, grade 1 or maybe grade 2 Latchman. All of us. So, but the biomechanical study says that it should not be done.
Okay, Nagmani.
I agree with Naveen.
Now I guess, sir, Vivek is going to take over, sir. And I would like to ask Vivek one question. Vivek,
Yes.
this has been on my mind, and Jagdish also asked. This is one question when we're talking about basics. What he has asked is, how do you know the knee is irritable? What knee are you going to call irritable? Because we talk about irritable, non-irritated knee and what is knee. So how do you define an irritable knee? That's what it's been on my mind also, and Jagdish has rightly asked. And this is the last question which we're going to entertain, and then we
Okay.
can move on
Okay.
ahead with basic
I would like to ask this
Vivek, please
question to
take over.
Rajiv sir.
Thank you.
He was the one telling
Yeah.
me the irritable and non-irritable knee.
Yeah. So I said a quiet knee. Okay. So
Yes,
anyway, I'll
yes.
answer this. So painful knee. Okay. Number one, whose range of motion is restricted. It appears swollen, and sometimes may appear a little red also. So a little bit of erythema also. So that sort of a knee would be an irritable knee, if that's an irritable knee. Now, when would we know that the knee is quiet? When the swelling has subsided, when the pain is much less, or the pain has reduced to a significant level, and when the swelling has reduced and the ROM is mentioned, ROM from probably 0 to 120 degrees. So a good amount of extension and a normal extension and up to about 120 degrees. So that would qualify for a good ACL.
Rajiv,
Okay, I think
Not the time.
yes,
let us
I
proceed.
agree. Can I just add that
Uh-huh.
there is a classical feature of roller.
Yeah.
Those are the feature of inflammation. If you have the feature of inflammation, probably this is an angry knee.
Yes.
Okay.
Oh my God.
To all the participants, it's a humble request. Kindly mute your microphone because it's causing disturbances. And some of them more. Please, thank you.
I finished. I think that's what I have to say.
Okay, I think
Vivek, it's up to you now.
Okay.
Yeah.
Go ahead.
Let us start with the second case. Okay. So I would like to ask Naveen sir to take this case. Okay. 35 years old male. He had history of twisting injury while playing football 1 year back. He is 35 years, history of injury 1 year back. He had repeated instability. MRI was done at some point of time, diagnosed as ACL tear. He consulted some orthopedic surgeon and advised for conservative treatment. The bad thing is he had one sort of steroid injection as well. So now he had repeated, he had again giving away 2 days back while jumping, while playing volleyball. And now he came to you with the severe pain. Naveen sir, what is the problem with this case?
Probably because of his ACL tear, he was continuing to walk on his unstable knee and continue some rotational forces are going on. And now because of the 2 days back injury, he must have injured his medial meniscus, and that lead to the severe pain. Probably bucket handle tear might be one of the case.
So that was wrong with his knee. I wanted to ask you what was wrong in this whole management. He had conservative treatment, he had steroid injection, everything.
In 1 year back when he was diagnosed at the MRI, age is 35-year-old male. So probably at that time he must have gone ahead with the ACL reconstruction.
Okay. Any difference in opinion, sir, Rajiv sir?
No, I think everything is wrong with this treatment.
Okay.
Now we need Dr. Naveen to do the correct treatment.
Okay.
Everything is wrong.
So this was his knee. This was the picture of his knee. Naveen sir, does this picture of his knee collaborates with your suspicion, sir?
Yeah, probably you can see there's a fixed flexion deformity on the right side. Absolutely. On the same knee, and there's a locked knee.
Absolutely correct. Absolutely correct. Yeah.
So how would you approach this condition, sir? Naveen sir again.
Now I have to again diagnose what the clinical diagnosis, what I have made is right or not. So I have to go ahead with the, of course, X-ray and MRI, and then
these are the MRIs. Okay, what next?
Probably what we have suspected is there is a bucket handle tear of the medial meniscus. ACL is not seen or totally torn in this coronal film, and yeah, probably we'll have to go intervene arthroscopically with the cruciate ligament reconstruction and repair of the bucket handle tear.
When, sir? In previous case, We waited for about 2 weeks until the knee became silent. In this condition, when?
Here, immediately we'll have to go.
Okay. Any difference in opinion in panelists? Amit sir, you want to add something?
Immediately means it is not, you know, the day he comes to you. You still wait if the knee is very. You can still wait for 2-3 days. Let it quiet down. If there is a massive effusion, let the effusion settle down a little bit. Probably next, I'm planning to operate him within a week, but not immediately, not next day, tomorrow.
Sudeep sir?
Yeah, definitely. I'll wait for the knee to become a little quiet and patient cooperative. Actually, I had a more or less similar case nearly 6 weeks back, where the patient was going around for 5 years with the ACL injury, and he came back with a similar history with the bucket handle tear, and add to that, he had even had an osteochondral lesion in a very young 25 years male.
How
So
long
this
will
kind
you
of
wait?
practice hasn't been going.
Sir, how long will you wait in these type of conditions so that the knee becomes quiet?
Maybe probably 2 to 3 weeks maximum. In between, he has to undergo a lot of physiotherapy and exercises. We have to wait till his knee becomes quiet.
Okay, Rajiv sir, there I have mentioned history of steroid injection. If the steroid injection was there just 1 week back, then will you operate this patient or will you wait for the surgery?
The thing is, Vivek, I don't think the steroid injection will have any importance over here, right? The thing is, basically, when you look at his MRI, you don't see too much of bony contusion.
Okay.
If you look at his MRI, right? I can't see his sagittal lateral condyle views, but on all the films that you provided, there's not much of bony contusion.
Yes.
So probably we can go in for this knee early, not on the first day, but early. We would
will you be
immobilize this
worried
patient.
with that steroid injection for the risk of infection, sir?
Yes, I would be worried, but I can't wait because of the steroid injection. Because see, we can wait for some time, for a week or so, till the patient settles down. If the patient has less pain, you can even start giving gentle ROM, maybe not extension, but gentle flexion, ice the knee, right? And in a few days, I think we shouldn't wait for the steroid injection. I think we should go in and probably first deal with the meniscus, take the meniscus back into place, okay, and maybe repair the meniscus if everything else is besides. You can even do the ACL later. In our circumstance, I'm not saying that I'll do the ACL later, but otherwise you could repair the meniscus, and if it's a very angry knee, you could do the ACL later when your knee becomes quiet.
Any of the panelists who will
looking at his one last thing, but looking at his MRI, I don't see bony contusion. So I think we can do his ACL and his meniscus in the same sitting.
Okay. Any of the panelists who will do ACL and meniscus separately, or all of them will do in same setting?
Same setting.
Okay. So this was his arthroscopic picture. After the meniscus has been addressed, this was his arthroscopic picture. There was a good amount of remnant, and remnant was gone and attached to the lateral femoral condyle. Arjun sir, in such type of case, how do you like to proceed? Will you, how will you prefer your technique of surgery? What is the special technique in these cases where there is so much of scars? It seems like just the intact ACL.
Since the duration of injury is over 1 year, you said.
Yes.
So, yeah. And there is a bucket handle tear of meniscus. Did you saw it?
That has been addressed, sir. That has been repaired. Now we have focused. Now we have shifted to ACL, and while doing ACL, there is good graft, good not graft, good scar. It's a type 3, type 1 scar.
That scar should be removed.
Okay.
And clear the knots.
Okay.
Because if you leave the scar as it is, that can lead to cyclops lesion later on.
Okay.
And so I like to go with the standard ACL reconstruction, standard technique.
Okay. Sudeep sir, will you debride all of these scars or will you preserve it?
No, I'll not try to preserve it because because if I try to preserve it and put another graft there, I'll be worried about the cyclos lesion. And this scar is non-functional, so I feel that there is no point in preserving this scar. So I'll have to debride it completely and do ACL reconstruction standard way.
I think Rajiv sir is not happy. Rajiv sir.
No, I'm happy.
You will debride
I'll
this
do an
all.
ACL reconstruction in this.
No, no, you are going to
No, I
debride
won't
all
debride
the-
it all. I will preserve. I will preserve. Yes.
Okay.
No, I will not debride all. I will preserve as much as remnant as necessary and do an ACL reconstruction.
Naveen sir, you will debride it all or you will preserve?
I will divide on the femoral part, but the tibial part, I think I can preserve a lot of remnant.
Okay,
Sir,
there are three opinions now.
is
Debride
it
all.
fibrous tissue
debride-
only?
This is remnant of ACL.
Vivek, can I add something?
Yes.
This is something which is very, very interesting.
Yes, sir.
Because if you see that what happens to the remnant after the tear is very interesting. Either it's attached to the PCL or it is attached to the condyle. So if it is attached to the femoral condyle or if it is attached to the PCL, these structures, whatever it is remnant, it is scar tissue, but literatures have shown that this provides certain degree of stability to the knee joint.
Yes.
So there is no point removing this, whatever tissue it is,
No.
there is no point removing this tissue because it has some point on stability, number one. Number two, if you see this scar tissue, whatever tissue it is, this is scar tissue, this is well vascularized. You can see the blood vessels going all around from either from lower to up, or so this is a good source. Yes, in the remnant of the ACL, this is a good source of vascularity as well. So it makes very nice sense. And if you go to current literature, which also says that probably remnant preservation will preserve your organ of proprioception, which is mainly localized into the femoral footprint and the tibial footprint. So if it is possible, in my hand, this is straightforward going to be a remnant preservation ACL reconstruction.
Arjun sir and Sudeep sir were worried about the cyclops lesion. Aren't you worried about the cyclops lesion in this condition if you preserve all those?
You are absolutely right. Cyclops lesion is one of the complication of the preservation of the remnant. But if the remnant is loose on one side, loose, either it is in the femoral side, then it can flip back and come out entirely. But this is not loose. What can happen is that is called the clouding of your notch. You have a good amount of remnant and you put a 10 mm thick ACL graft, then there is a crowding of your notch. So you have to do, if your remnant is preserved, probably you will get away with a 7.5 graft rather than a 9.5.
Yeah, which is good in our circumstances.
Yes, which is good in our circumstances. And put a smaller size graft, but try to preserve the remnant. This has
there has been paper that if doing all remnant preservation, if you are doing ACL reconstruction, you may need to do notchoplasty as well. How what is your take on that, sir, Rajiv sir? To accommodate the bigger size graft or to accommodate graft as well?
As far as possible, no notchplasty. As far as possible.
Okay.
Yeah, as far as possible, no notchplasty. Because there are various papers. Some papers say the notch even regrows more aggressively. Right.
Last 3 years time, we have done about 350 remnant preservation ACL reconstruction. We have never done a notchplasty. Notchplasty.
Yeah.
Yes, not only notchplasty. Soft tissue notchplasty you can do.
Amit sir, Naveen sir has raised some valid issue. Remnant preservation means preserving whole of the remnant from the tibial side to the femoral side, or preserving remnant, some remnant at the tibial side. What is it actually?
Remnant preservation doesn't mean that you preserve only in the tibial side. Remnant preservation means you preserve whatever you can preserve of the ACL that is there, both from the tibial as well as the femur. However, there is a catch point that the preservation of the remnant should not compromise the location of your ACL tunnels. That is very, very important. So if your remnant is obstructing placement of your tunnel, then probably in that case you have to do a little bit of soft tissue notchplasty, remove some tissue. Otherwise, you try to preserve as much as possible. It's just like a bundle specific. When you are doing a bundle specific reconstruction, you do not remove the other bundle. Because that is it. The other bundle is providing certain stability. Just like that. This may not be a bundle, but this is a structure which is bridging tibia to the femur and try to preserve this tibia and whatever you can. And this is the current trend, and literature have clearly mentioned that those people who have preserved remnant have better proprioception, less secondary injury, less amount of that is required in this patient. However, this patient will definitely have a higher chance of cyclops lesion. For that, you have to know various technique by which you avoid the cyclops.
And then you also can have the confusion in the site of making the tunnel on the femoral side also.
Yes, that exactly. Yes, sir. So,
And so
do you
that
have
like
any special techniques how to do those tunneling when you preserve the ACL, sir? ACL remnant?
like there are certain like technique they have been mentioned. There's some people they do use even Siam to
Yes.
identify the point of entry also.
Okay.
And there must be some special technique like to preserve the femoral attachment. Uh, to Amit, from where do you make a tunnel, like inside out or outside in?
Amit, sir, you
For
have
femur,
question.
In this situation, yeah,
inside
in
out,
this situation.
inside out. There are various literature which can say that outside in is a technique by which you can preserve most of the remnants in the from the femoral side also. But I do all
But
inside
that
out,
can lead to,
because you can just
yeah.
lift. This is lax. See, the ACL, which is a remnant, is lax. You can just use your probe or use some structure just to lift it, so that you can go behind the ACL and see the over the top position and place your tunnel there.
How do you
But
prevent
during
the
reaming,
injury?
there is a chance. Sorry.
How do you prevent the injury to the tissue? Like while reaming, you can have a
during reaming, there is a certain chance of injuring the structure. But what you do is you don't ream from the skin itself. You just go push your reamer in. Use a femoral reamer, which is only reaming in the apex. Push it in, and then you start rotating it, and rotating from right outside.
So I think what we can conclude from this case is there are multiple times, if the surgery is delayed, there are various types of remnant. The remnant may be attached to PCL or remnant may be attached to the condyles. So as far as possible, the remnant should be preserved, but remnant must not be preserved.
Okay, I would like to ask.
Yes, sir.
I would like to ask one question.
Okay.
To panelists.
Okay.
If the same stem, if it is in one case it is attached to the PCL and this is attached to the femoral condyle, then how it differs while choosing your this remnant preserving technique? Like what precaution would you like to take?
Rajiv sir, would you like to take it?
I didn't understand the question.
Now the scar is type 2. The scar is gone and attached to PCL, not to the condyle. Will you still preserve from tibia to PCL, or will you debride it?
See, the basic thing is how I look at it is like, see, an ACL injury, nature has a way of preserving the instability of the knee also. So sometimes what happens, the ACL stump goes and gets attached to the PCL.
Okay.
And sometimes that's why they say in chronic cases, you don't even have Lachman positive. Okay, because the ACL is gone and scarred to the PCL. So that sometimes fools us, right? Because we see a torn ACL, but then the tests are not positive. Right. Okay. So see, as far as possible, even if it is attached on the PCL, you must try and save the remnant, because see, especially in our population, we get a very small sized graft. Okay. So we are doing all this to basically bring about stability in the knee. So if you have a graft which is even faster to the PCL, okay, you can preserve the remnant and do an ACL reconstruction. Because the goal is not only to get a nice looking graft, the goal is to maintain stability, basically. And nature has a way of making things stable. So why do you want to go destroy that stability?
I absolutely agree. And it has to be looked at by two ways. One is the remnant, if it is attached to the femoral condyle or it is attached to the PCL, both will provide certain degree of stability. And there are collagen, which is a natural collagen of ACL. So all purpose of doing a ACL reconstruction is putting more and more collagen, having a larger size diameter. So if you have remnant preserved, so collagen is all natural collagen is already there. So probably you have to preserve as much as possible. That is debated. The second thing is the proprioceptive organs, which is there. So why more ACL fails even after the ACL reconstruction? Because people do not get a good proprioception from the grafted ACL until unless they are well vascularized. So this is a vascular structure. This is a viable structure which will have certain amount of the proprioceptive organs. So whenever possible, there are more logic to prevent But one catch point again to emphasize that it should not compromise your positioning of the tunnel.
Yes,
So
exactly.
if you place improperly your tunnel, by preserving the remnant, it is
Yes.
not going to function. Your ACL is going to fail.
So I
So
think
that is a very
Amit,
important point. But whenever
Amit,
possible,
yeah.
yes, sir.
Amit, do you manage the
yes, yes,
the flipped part of the remnant also sometimes if it is flipped anteriorly and it is not adhered to the
yes,
to the knots or toward the PCL, then that can flip anteriorly and that
yes,
cause
absolutely,
impingement area extension
absolutely,
line.
absolutely.
Yeah.
You are right, Arjundai. We have a lot of these cases. In these cases, what we do is we apply a stitch by into the remnant of the stump, and then in that case, we do not fix with the endo button in the femoral side. We apply a few two sutures into the femoral, one or two sutures into the remnant, then make our tunnel and then pull it through the same tunnel, the thread. The graft and the thread goes from the same tunnel, and you fix with the interference screw that will hold your thread that is pulling your this thing also. So
So
in that case, we
Okay.
say it is a repair with augmentation. So
so
hopefully
I
next year
think we
we'll be
have to
coming up with
conclude it, sir.
our
Okay. I think we have to conclude it.
you don't want to advertise my research, na?
No, sir. It's getting too long. That's why, sir. So,
Okay.
what can
So
we conclude with?
please let me tell that
Yes,
we
sir.
are coming up with the new classification of arthroscopic classification of ACL tier, which has been presented by Nagmani Singh in Biratnagar itself, and then we have modified that classification, and then that will give us an idea how actually you have to deal with the remnant of the ACL as well, and hopefully
Okay.
next year it will be accepted in
So I think
I'm aware of that classification, Amit. I'm
yes,
aware of that
public.
classification. I know
yes,
where you've done it already. I've seen it. It's nice.
yes.
Nice. Very innovative. Very
It's safe to
innovative.
conclude that preserve remnant as much as possible, but not at the cost of distorted anatomy or malpositioning of the tunnel, and not at the cost of formation of any cyclops. So it's good to preserve the remnant because remnant is a source of some extra collagen, remnant is a source of vascular supply, and remnant is a source of proprioceptive organs. So it's always good to preserve the remnant. And I think that is our conclusion, right, sir? Okay.
Yeah.
Let's take
Okay.
some questions.
Yeah, Vivek, I would like to come in now. There are
Okay.
certain
Okay.
interesting questions. Dr. Sravan asked pertaining to this case. He said that in the first case, when you showed the MRI, he's asking how often do you find your MRI findings which is matching to your arthroscopic findings? That's the first question. So you can ask any of the panelists you want. So how often the panelists find that their arthroscopy and MRI picture is just the same, the way they read?
Okay, Srondai is from Bharatpur, so I would like to ask Sudeep sir only. Please, you take this question, sir.
Most of the time we match, but many times we have to read. If we depend only on the radiologist for the finding, many times it differs. So we have to start reading MRI ourselves. If we do that and start comparing in your arthroscopic finding, gradually most of the time your MRI finding and arthroscopic finding it matches. But if we depend only on the radiologist, then many times it differs. They say there is a meniscal tear, grade 2, but on table we may not find it. So
Okay.
this is what I found. We have to start reading MRI finding, and at the same time, when you do arthroscopy, you compare your finding with that. Gradually, you tend to develop your judgment.
Ishwar sir, I think you would like to answer this question.
What the same question?
Yes, sir.
Yeah, I quite agree with Dr. Sudeep. Like you have to do your MRI reading yourself. You should not be believing on what the radiologist is reporting because you are the first person who sees the patient, and you should be corroborating your finding with your MRI, your clinical finding with your MRI finding. I mean, there will be sometimes some cases which you will be puzzled with, but most of the majority of the cases, you should be able to correlate your clinical and MRI finding, provided that you do your MRI reading yourself.
I think I really agree with our panelists because we are the ones. Amit sir, you would like to add?
Yeah, he's raising his finger
Yeah,
rather than hand.
Yeah.
So I think that's
Yeah, I just want to add that give a good news to all of us by saying that we are not bad. we have, I'm just recently analyzing, preparing a paper of 234 MRIs compared with the arthroscopic finding that we did on last 7 months time. And this, the sensitivity, specificity, positive predictive value, negative predictive value, and the efficacy of MRI read by the radiologist and read by the orthopedic surgeon is not much of difference, number one. The second thing is, when we compared with the other international publication, this is not much of difference. So some say that it is between 60% to 90%. We have found that about 87% sensitivity of MRI to detect ACL tear or whatever. But this will change according to the structure and structure. For lateral meniscus, the sensitivity is very, very less because of the various reasons. Its placement, its orientation to the MRI and everything. What we have come up with a study which is compares the sensitivity of MRI to detect ACL meniscal tear in ACL torn group and the ACL intact group. And it has shown that probably in ACL torn group, the sensitivity is really low. And this is not only in our case, and this is compared to the others also. So 60 to 70% sensitivity of lateral meniscus tear, 80% sensitivity of the medial meniscus tear in ACL tear group. So the situation is not that bad, the conclusion of our paper is situation is not that bad, but still it's a very important point raised by Sudeep Dai and the Iswar Dai that we should learn reading our MRI ourselves and correlating our MRI clinically, and the correlating our clinical finding with the MRI is very, very important.
Nagmani, you have more questions?
Yeah, Vivek, there are a couple of more questions. One is very interesting pertaining to this case asked by Dr. Bidur. He asked in two phases. Maybe Rajiv sir was talking about it initially. He said that what physio would you advise in locked knee? And the second part was, is it wise to complete meniscal repair first and then go for a subsequent ACL reconstruction? Or you do it the other way around? That's his question. Because you're repairing the meniscus in an unstable knee, is it going to be wise enough to do that in staged, or you want to do it simultaneously? That's the question which Dr. Bidur asked.
So he is asking to Rajiv,
can I answer that? Yeah.
Yes,
can I answer? Yeah.
Yes.
So, Dr. Bidur, the thing is basically, see, what I'm trying to say is we were talking about a very inflamed, angry, swollen knee. I am not implying in any way that in any quiet knee that you go in for meniscal repair and then go in for ACL reconstruction at the second stage. No, we would all do it in the first stage. But if you found the patient had a locked knee and the knee was not moving, there was a lot of pain, the knee is very angry, there's redness there, then I am implying that you could do a meniscal repair, continue the use of the immobilizer. After a week or so, you could again go in for an ACL reconstruction.
Actually, Actually, Rajiv, this was not the question. I understood that Bidur wanted to ask which one to do first, either to do a ACL. So you are doing at the same setting, but it is wise to do a ACL first and then repair your meniscus, or you repair the meniscus and then you do a ACL first. I think that is the question.
Yeah,
is it right, Bidur?
Yep.
Yeah, so the way we do a meniscal repair and ACL combined is, what we do is we pass our sutures. If we do an inside out repair, we pass our sutures and then we do the ACL and tie the sutures in the end.
Absolutely. Why meniscus has to be done first before ACL is because when you do meniscus, you have to put the knee into the extreme of the valgus or extreme into the varus position. So in that case, probably you are putting more stress into the ACL if you do meniscal repair after the ACL reconstruction.
I'm not implying that you do so. I'm saying in these extreme conditions where you can't do the ACL, then
Bidur also agreed that his question.
I think Naveen sir wants to add something.
The thing that completing the meniscus repair and then going for ACL reconstruction, sometimes you have to make a femoral tunnel, then you have to hyperflex the knee. So what my suggestion is, you just put the sutures, reduce the bucket handle tear, and then before tying, you just make a drill hole in the femur, and then
exactly what I said.
And then so that subsequently, that is the answer of first question. Another, he has asked for the physio. For the physio, for this bucket handle type of tears, you do physio as you do for the other cases. Because bucket handle tear, when you give weight bearing, the foot disappears and the whatever unreduced part is there going to the periphery, the chance of healing is high. But had we need another tear like the flap tear or the radial tear where you have repaired, in those cases you have to restrict the weight bearing and the range of motion as well. But the bucket handle tear almost similar, just doing ACL reconstruction isolated or with the tear, both will doesn't differ too much.
I think we'll continue with our discussion, right?
I want to add up a question.
One last
Oh.
question, Dr. Vivek. This was asked by both Dr. Neerav and Dr. Susil Thapa from Chitwan.
Okay.
They posted it in a different way. What they were asking regarding the remnants is, when you're doing a remnant preservation, how much ACL remnant is to be left behind when we are doing remnant preservation, so that we do not have cyclops problem later. So
Okay.
what is your adequate amount of remnant which you want? And Susil posted it in a different way, but the meaning I suppose is the same, that how do you prevent cyclops in remnant preservation? And what is the
Okay.
amount of remnant you want to preserve?
I think Amit sir wants to
let
answer
me
it.
yes
Okay.
let me answer this, that you preserve as much as remnant as possible, and once you have preserved it, there are so many types of cyclops. Then at the end of your surgery, if it is an acute, when the proximal is not free, then you bring with the suture, fix it to the femoral condyle. If it is a chronic one, usually cyclops will not occur, because cyclops of remnant preservation will occur if the proximal ACL flips into the tibia. So you make sure that it is attached, well attached. There are so many ways. Dinshaw sutures that remnant into the ACL so that it doesn't flip. I pull it out through the tunnel and then fix it on there so that it can be tensioned as well. And then what is important is, at the end of your surgery, you do an extension of your knee joint. You do a good extension of the knee joint. You look at the footprint of the tibia. You can see that there is no cyclops and there is enough gap into the femoral notch. Then you are okay with that. I think this will answer Neerav and Sushil's question.
Okay. Vivek, one last thing. So Amit sir and Rajiv sir both were against notchplasty, but there are audiences which are asking as to if they do notchplasty or not, and if some of the experts, if they do it, what's their adequacy of notchplasty? Because that might be just the view of Amit sir and Rajiv sir, but maybe our other senior panelists might do it.
Okay, Arjun sir, I think, would you like to answer this?
Yeah.
How common you do notchplasty in your cases?
These days, since I started doing anatomical reconstruction, I do not do any notchplasty. I simply clear the soft tissue. If you see, even in literature, it has been mentioned in some literatures that whatever bone you remove, it will again reform.
Okay.
And so that same notch can occur.
Any of the panelists who do notchplasty, even after
Earlier,
transportal reconstruction?
While doing transtibial, in the certain cases who have a very narrow, this is individual variation. Some of the patient will have a very narrow notch. So in those cases, earlier I used to do this. Once I started transportal, I have not done any.
Okay.
So that is obsolete. That is obsolete, I guess.
No, not obsolete. Not obsolete, Nagmani. I think it has to be decided at the end of the surgery, as Naveen was saying. Vivek also presented there are different types of notch in case of ACL tear. So I agree that it has to be decided at the end of the surgery. You do a full extension of your knee, and then your ACL should not be impinged over anything. If it is impinging, then you have to do a notchplasty. Usually that happens when your proper tibial tunneling is not there. Either it is too anterior or it is too medial or lateral. In that case, your ACL will impinge into the medial condyle or sometime into the lateral condyle. So you do not preemptively decide, I'm going to do a notchplasty in this case. I'm not going to do a notchplasty in this case. So at the end of the surgery, you do a full range of motion, especially in the extension. You see that it is not impinging into any place, and then you decide if you need, you do a notchplasty.
So basically, your adequacy, Amit sir, would be that when you extend and there is no impingement until that part, you will resect the bone, right, sir?
Yes, and absolutely agree with all the panelists and the chairman who say that in anatomic, truly and properly done anatomic ACL reconstruction, notchplasty will very rarely require.
Okay, Vivek, that was the question set, Vivek. I'm handing it over to you, so you can proceed if you want.
Okay. let's continue with our discussion. Among the various errors that happens during ACL surgery, the technical error, the position of the tunnels is very important and very common cause of failure of ACL surgery. I have given you some X-rays of the technical errors in this slide. So my question is to Naveen sir. Do you always do X-ray immediately after your surgery?
Yes.
All your
I
patients get
always
X-ray,
do it.
right? Okay.
Yeah.
Any of the panelists who don't do X-ray?
After the surgery?
Next day.
Yes.
Next,
Intra-op
everybody do.
or post-op?
Post-op.
Intra-op or post-op?
Post-op.
Post-op, of course.
Next day. Okay.
Yes.
Okay. If it's next day you have done X-ray and next day the X-ray looks like this, then what will you do? Rajiv
Which
sir.
one?
First
Which
one. Rajiv sir, it looks like this. First one.
That's an ACL reconstruction.
That's not ACL reconstruction. That is PCL. So if
That's what.
the flip is it is soft tissue flip, then
If it's a soft tissue flip,
would you go in again and readjust it, or you just?
I think I would just. I mean, how do I explain to the patient? Okay, the thing is basically okay.
The, deep inside,
I think I
there is
would
some problem, right?
Yeah, yeah. You can give me a lateral view. I'll have a look at the lateral
No,
view
I don't
also.
have lateral view, so sorry.
Okay, so if this is the view, I think I'll just leave it like this right now.
Okay, in which condition you will go in and repeat your surgery out of these four?
If the lateral view is not correct, with this amount, I'll just accept it for now.
In
Because
all
of various,
cases, you will accept, sir.
In all 4 cases, 1 minute. No, the flip is the ACL. This is an ACL and a PCL, right?
Yes.
The second one.
Yes.
The button is flipped inside. How
Yes.
does that happen? The button. This one you'll have to revise. The second one. Second one. The
third
third
and
one also. The tibial screw. The tibial screw is totally. Everything is wrong in the third and fourth.
And
yeah,
fourth?
the third and fourth. Everything is wrong.
Yeah.
So you are going to revise.
The third and fourth are the same, right?
Yes.
The third and fourth are the same. Yeah, so I'm going to revise the second X-ray, the third and fourth X-ray. All of these I'll revise.
Okay.
The first one, maybe I'll wait. First one, maybe I'll wait and see.
Any of the panelists who would like to wait?
Can I add something?
Yes, sir. Yes, sir. Yes, sir.
Yeah, to avoid this kind of complaint, we always have a CM in a OT. I always do check with my CM at the last of my surgery.
Okay, that is.
So next day it becomes very embarrassing to explain the patient. So if we do it and check it under CM, and we are in OT, we still have a chance to revise the patient. So it becomes easier to explain the patient and avoiding the embarrassment.
Yeah, that is correct. As Dr. Sudeep said, sometimes also you can have a confusion of whether it has flipped well or not.
Okay.
In that situation also, you better have a CM done.
Yes.
Okay, then
so Arjun,
if you do at the end of the surgery.
Okay, Arjun sir, I have 4 cases, 4 X-rays over here. When will you wait and when will you go in again in these 4 X-rays?
Yeah, I agree with Rajiv. And in first case, it has flipped with some soft tissue in between.
Yes.
Okay, and that in that situation, I go little bit less aggressive rehabilitation. Okay,
but
and in other 3, I think that.
Okay, any of the patients will wait in all these 4 cases? Amit sir?
Vivek, it's very interesting, that rather than looking at these X-rays and planning what I'm going to do, we have to think what caused this is very, very important. So we should try to avoid all these 4 situations. In number one case, which is a PCL, which is flipped little outside, this is just error of not making a good marking and not giving a gentle pull. So you have to mark your graft. If it is a soft tissue graft, you have to mark your graft. If your graft is too much in, your marking is not visualized. You have pulled it more inside. If your marker is still out, it is you have flipped into the tunnel. So if you think that this has happened, probably that is the time you take your C-arm inside and then finalize where is your button.
Sir, agreed, sir.
If it is
Agreed.
not. So this
The problem has been agreed.
situation will not arise.
Problem has been caused. You are
already happened
with the
yes,
with the post.
That is for the prevention.
Rajiv very correctly mentioned it is very difficult to counsel the patient,
Yes.
but I'll still try to counsel the patient and do revision for number A case. Number 2 I'll do revision for that. Number 3 I'm not able to decide what is exactly error in this one. What error do you see? And number 4 definitely I'll revise and I'll counsel the patient and I'll revise. And probably it will be easy to revise if this is not my case. If it is my own case, it will be difficult to revise, but that is wise to do rather than leaving it alone and then doing a second surgery later on, making same tunnel. Probably go accept the error. There are so many ways of counseling the patient.
So my next question here is, if you want to go in, so if you have discovered this thing after about 48 hours, for example, 2 days. So if you went in, you will use same graft or you will use the new graft? Because by 2 days, by 48 hours, the graft strength will be decreased.
Yeah, I'll not change the graft. In the type 1, I'll open from the middle part of the femur. I'll put a post and then I'll put a suture into the button threads, and then I'll give a secondary this thing. In this one, I don't know what has happened. This is just your button is about to vomit it into the joint. So in this case, probably I might need to decide, because this part from the tibial part, it has already been cut. So it's not possible to pull it out. The graft will be short. So I'll take another graft. I don't know what is wrong in the third case.
Same X-ray, no?
This is a vertically placed.
Third and fourth.
The same X-ray.
AP and
1 and
lateral.
2.
AP and lateral.
Okay. So the third case. So this is not third and fourth. Not third or fourth. The third case, I have to revise the tibial tunnel in this one. So if I have to revise the tibial tunnel, the graft has been already cut.
Okay, my question is up to when the same graft can be used. If you decided to go in, for example, this surgery was done by some other surgeon and came to you, and you got this case after 10 days. Then you decided to go in, you will retain the same graft or use the new graft? Is there any time limit to use the same graft?
Vivek, after 10 days, probably case 1 can be, the graft can be preserved. Otherwise, in none of the other cases, graft can be preserved.
Any difference in opinion in panelists? Rajiv sir, you want to say something?
No difference in opinion.
It is less likely that patient will go to different surgeons in 10 days.
Sir, Sudeep sir.
It is less likely that in 10 days patient will go to another surgeon unless you explain him that something has gone wrong.
Yes.
Very true.
Okay.
Very true.
If it was my case, I have to do very, very dramatic explanations, have to explain and do it the very next day. and bang your head and think, how did I do this?
Then how do you explain? Can you give some clue, Rajiv?
I'll tell you if it happens. Because that will be a lifetime memory.
Okay.
So I think, as Amit sir has mentioned, the prevention is better than care. So we have to prevent such mishap from occurring than talking about how to counsel and how to everything. I think that is the more important thing. So coming about the follow-up of these ACLR cases, how often do you do X-rays in follow-up? Rajiv sir.
In follow-up?
Yes.
For ACL?
Yes.
No, I don't do X-rays on follow-up.
Never.
Unless it's a very tricky situation, like let's say later, yeah. For example, if my patient complains of instability later on.
Okay. So
any chances of failure of my procedure, then just to check if there are any signs on the X-ray of failure, then I will do my X-ray. Otherwise, why should I do an X-ray?
Aren't you worried about tunnel dilation and all?
That is later, no? Not in the early. How long are you saying?
Years, maybe years.
Yeah, maybe in years. But even if there's a tunnel dilatation and the patient is asymptomatic, I'm not going to do anything about the tunnel.
Okay. No need of X-ray for you.
No need of X-ray.
Only once.
Unless the patient has any complaints.
Any difference in opinion among the panelists, sir?
I think one follow-up X-ray is necessary and for your documentation that you have done things right on your day one. So I think one X-ray is post-op is justifiable.
Yes. Post-op.
I,
Yes.
I have one question here. If you have done like bone puddle tendon bone graft, would you like to see X-ray after some weeks or months to see the healing?
Yes, I agree with you. If you've done bone puttle or tendon bone
Yeah,
graft,
yeah.
maybe you need an X-ray. Yeah,
Yeah.
Yes, yes.
So I think we have already crossed 2 hours. We are about to cross 2 hours mark. So I have one more case remaining. Would you like me to continue or stop here?
Vivek, I think it's getting interesting. Corona epidemic is giving us so much time for panel discussion. I think we should move with the fourth one also. Vivek, since there were no questions, I had a couple of queries. When we talked about it, the C-arm picture. A lot of panelists talked about C-arm picture when they get it done in intra-op, because I'm a bit confused because we don't do very often in our practice. And even Dr. Sachin Tapasvi, when he found that X-ray, and once I had asked him, like, if you tunnel and if the endobutton is placed in soft tissue, how do you do it? And he said the best way is to not get an X-ray done, and you rather do a clinical exam. The best way is that you examine it on the table, and if it's not lax, and if you're finding that if it is taut enough and your knee is stable, just let it be alone rather than
Nagmani,
X-ray. Any difference in the opinion from the panelists? That's what I wanted to ask.
Let me tell you, Nagmani, that Jacob's study, which is done in 2014, published in Arthroscopy, they have measured the distance from the cortex to the button. If it is more than 2 millimeter, there is a gap of more than 2 millimeter of soft tissue between the button and the cortex. The knee is going to be lax in a later point of time, and the 80% of these patients, they will require a revision surgery because of the instability. So rather than just trying to avoid seeing the complication, try to actively search for the complication intra-op as well as post-op, and then if possible try to deal with them. There are so many ways of dealing with this one. One is I said that cortical, you can add up cortical fixation. The other one is you can add up since the tunneler is still fresh, you got it in the second, you put up one interference screw and do aperture fixation. This kind of thing can be done.
Fair enough, sir. But, so the distance is 2 millimeter on the post-op X-ray, right, sir? And that's your cutoff mark to revise it. With augmentation with another screw or something. The way
not revise, revise, refix. Try to find out some
refix. And sir, how often do you do the C-arm procedure in your OR, sir?
You know that we don't use it. We don't use it regularly. We do visual fixation. We have to identify the marking. Where is our marking? Our marking is right at the otis or the aperture. Or
we would fix it with the marking of the graft, right, sir? In our case, we do it with the marking of the graft rather with the C-arm. And that was the question. So basically, we don't use C-arm that often as people say. And the X-rays also, you don't tend to get it routinely, right, sir? Post-op X-ray routinely. Routinely on the day one or something.
Until there are certain indications.
So Arjun sir is on the side that he'll do it routinely on the first day. How often would we do it, sir? Rajiv sir, Sudeep sir, Amit sir, Iswar sir, all of you, sir. Do you do it routinely or no, sir?
Post-op X-ray talking about. Usually C-arm always I check it most of the time.
No, post-op. He's asking post-op.
I'm asking about post-op, sir. Post-op X-ray. Amit sir doesn't do it. I know that. And me, Vivek and all also don't do it. Iswar sir and Rajiv sir, Naveen sir, the other panelists. Do you do routine post-op X-ray or not?
I do routine post-op X-rays.
Yes. Okay. Yeah, immediate post-op X-ray.
Why, sir? How would you benefit from that? Yeah, exactly. That was the question, sir. On the first day.
No, I won't benefit, but the patient needs to see, no?
Yeah. Okay.
The patient needs to see. So because the patient has to see the endobutton. Yes, absolutely, very important.
This is to evaluate myself.
And hey, one thing. I remember during the previous BNB course, not this last one, the one which was held at Dhulikhel, Horizon Resort. over there we had, I think so, just remind me, you guys, like there was this discussion, if the endo button, if there is a soft tissue impingement between the endo button and the condyle, before we actually fix the tibial part. Okay, I think Dr. Tapasvi or Dr. Kiran Acharya, he was there at that time. One of them had mentioned that you can use the knot pusher to push the endo button down. Something like that was mentioned there. These things, troubleshooting. Something like that was mentioned there. As far
There are
as
various techniques. We'll not go into that. There are various techniques.
But the routine thing is just
But
for the
actually,
the
patient
routine
and for
thing is,
yourself,
if your
right, sir? That-
endo button normally flips and everything goes normally, we don't use the C-arm at all. But we do
No,
get
no,
a
the
post-op
post-op
check.
X-ray. Post-op X-ray.
Post-op
is
X-ray, I get
preferred
it
most
done.
of the time.
I get post-op X-ray done.
As
To
Anil
even
has-
to
Anil
even
has
check,
also
to
said-
even check whether my tunnels are correct, whether my
will you
ACL
change?
graft is in the correct position. Sorry.
Yeah, that's
will you
what, sir.
change
Will you change if you find something, sir?
No, I don't change, but that gives me, to learn for the future. I
No,
learn
yeah,
that
for
this
the
is
next
okay.
for the next patient.
Yes.
But why? But why next day? I usually do after 2-3 weeks when the patient is comfortable. I can do different views and all. So probably it can be debated. But Naveen wanted to add something.
Yeah.
No, as you said, no, the one of the thing you said that a 2 milliliter more button is out of the cortex, the chances of failure may be high. Another thing is Freddy Fu has said that you draw the axis in the center of the femur and then
Yes,
you
Naveen, correct.
measure that angle if it is more than
That
36
is there.
So at least you should know that how are chances that you are going to fail. Otherwise, you are very happy,
Very
man.
true.
Yes.
No. It's not that, Naveen. I'm not saying that I'll not do X-ray anytime, but there is no point doing X-ray on the next day itself, immediate post.
That agreed.
After
That
a
agreed,
week,
yeah.
maybe in 3 weeks follow-up time, you do X-ray when the patient is more comfortable. Because if you compare the post-op X-ray done immediately after the surgery, the views are not proper. You cannot measure what you are saying.
So
Either
Dr.
the
Nagmani,
knee is a little bit flexed,
okay.
the lateral view is not correct, lateral view is not correct. So the positioning of the limb becomes not comfortable. If you want to measure and test what are your tunnel positioning, it went well, learning for the future purpose, probably 3 weeks time, you do X-ray in proper view, and then you decide what is done.
Okay,
Dr.
Vivek,
Nagmani,
it's up to you
I think
now.
I will start with
Yeah.
the third case.
Let's go to the
Okay.
This is the last case.
This will be last case. I think.
Okay, yeah.
Whom have Rajiv sir? I have not asked you. This
Oh,
is
very
third
good.
case.
Come.
Please you take it. 30 years active male, history of injury to left knee, 3 months back. Limb was 4x4 at the time. Okay, and X-ray was done. He was said X-ray is normal. He was advised for brace and rest. He improved, but now he has restricted end extension of the knee joint, and pain is persisting. His left knee does not feel okay. His left knee feels weaker, and the weakness increases with activity. He had significant injury with limb 4x4 3 months back. X-ray was done. He was said some people said, and it was said normal. He was managed conservatively. He is improved than that time, but pain is still persisting. He cannot extend the knee full, and it has been 3 months.
Now, what about his examination?
Lackman is, there is some excursion, but endpoint is good.
Okay.
Pivot,
some excursion, endpoint is good.
Very
okay.
difficult.
Okay. Then extension restrict. What about his pivot shift?
A pivot shift is
anterior draw, pivot shift.
Negative.
Okay, is it possible? Not too much pain persisting.
Yes.
Left knee feels weaker. His pivot shift. What about the other tests? For the other ligaments, everything is normal. Only Lackman is lax. Endpoint is firm.
Excursion is some increase. There is some increase in excursion, but endpoint is good. Hard endpoint.
What about his menisci?
Okay.
Test for his meniscus?
Okay.
Everything is normal. What about his MRI?
MRI, don't you
MRI
like
is normal.
X-ray?
Yeah, X-ray is normal, you said, no? X-ray is done is normal.
That was said normal at that time.
Oh, okay. Then let's get another X-ray.
Okay. You have this one.
Oh. Okay. So can we have the previous X-ray? That X-ray was normal.
No, the patient didn't bring it.
So I don't think that X-ray was normal.
Avulsion of tibial spine.
Yeah, the X-ray doesn't look normal. That previous X-ray can't have been normal because now you have a big thing elevation over there, no? So that is
was
united at a wrong position.
Yes,
So
yes.
that's why this patient has a lax ACL, but his endpoint is firm. Is that it, Vivek?
Yes, sir. Yes, sir. So
Okay.
my point in mentioning this case is most of these tibial avulsions are very small avulsions and they are usually missed. So and missed,
Okay.
and after about 3 to 5 months, they come with lack of full extension because of locking, because of that
Okay, got it.
spike. So this was his MRI, and MRI showed the fragment being malunited, and because of which the endpoint is hard, but the laxity was there. So if
The MRI is also not normal. Nah?
okay, if you have such type of case,
Okay.
how would you manage this case, sir? Rajiv, sir?
He said 30 years old, active male. Okay.
Yes.
So, see, the thing is basically here we're dealing with a 30-year-old active male who has a Lachman, who has a lax Lachman, but his endpoint is firm.
Yes.
Okay. What are his normal day-to-day activities? What is he? Is he an active sportsman? Does he go to
He's
office?
an amateur.
Active means?
Amateur. He's amateur.
He's an amateur sportsman.
Yes.
Amateur
He wants
sportsman.
to stay active.
Okay. Now, what about the pivot shift?
Negative.
Pivot shift negative.
Yes.
Then I think I would counsel the patient and I would tell him that your ligament is lax but it's firm. If it does not result in your persistent if it doesn't result in giving way, and if your knee is stable, then probably I will not do surgery. This is 3 months after the injury.
Sir, aren't you worried about his lack of extension?
His lack of extension, okay.
Yeah.
Full extension.
Yeah. So with physiotherapy, wouldn't that be better?
Don't you think that this bone spike has caused lack of extension?
And impingement.
Yes.
Now, if that is the case, then I think I'll go in for an arthroscopy.
Okay.
Okay.
Sudeep,
I'll
sir,
go in for an arthroscopy.
any change in opinion?
No, I think we can still give it a try. He has just come to you after 3 months.
Okay.
So I would like to give him a try of some physiotherapy and see if his active extension improves.
Okay. Amit, sir?
Yeah, if you read our chapter, it's very important to do a X-ray in extension. If you do X-ray in extension and if you find out that the bone spike is abutting your femoral condyle, then probably it is going to damage your femoral cartilage. So you have to intervene as soon as possible. So if there is a gap in full extension, when you do knee in full extension, whatever extension available, and then there is a gap between the tibial spine and the femoral condyle, you can still try a conservative management. If in this case, when it is a bony block, I presume, if it is a bony block, I'll go with the arthroscopy. I just look at the ACL, how lax it is, and then I'll look at the tibial spine in extension. If I can get away, if it is already nicely healed, it is not a malunited. It is not non-union, but it is only malunited. If it is united, stable united, I'll just shave off the spine of the.
That will be my part of next question, sir. Naveen, sir.
Okay.
Naveen, sir, what will you do? You will wait or you will go for arthroscopy straight away?
The patient is having problem. He is having a lack of extension, and usually this tibial spine present in two ways. Either there is a non-union where patient come to me with the instability and pain, and another is a malunion where patient come with the extensor lag. And with this physiotherapy, if he is not improving, then I'll go ahead with arthroscopically and see what's the problem.
So we did arthroscopy in this case. This was malunited. There was good bony bump anteriorly, and this is the case. If you find the case like this, what will be your take, sir? Rajiv, sir, the ACL seems to be well healed, but the bone is malunited. What will you do?
I think if that is impinging and he's lacking extension, then I will go and do an osteotomy and try and fix the malunion.
Okay, osteotomy.
Create a crater and at the malunited site, I will do a small osteotomy. I will basically remove that. I'll clear the crater and try and bring the ACL down. If that is impinging, that is the cause for his extension.
You will just recreate the fracture and fix it, right, sir?
Yes, and fix it.
Yes. Who will not recreate the fracture, or who will just save away the protuberant part?
I'll try to
see,
figure out the protuberant part and see if the extension is gained. Then
Okay.
only go for refracture.
Naveen sir?
Yeah, I also like to see how much it is just engaging over on the femoral nose part. If it is very small part, then I will save and go ahead. Otherwise, I will do the way Rajiv has said, recreate
Mainly,
fracture.
we're just going to take care of the extension.
Okay.
We're going to take care of the extension.
Yes. Amit sir?
हेलो सरोज भाइ त्यही भयो एकछिन ल 5 मिनेट म आउँछु है
Amit sir?
ल
according to the clinical pictures, it was a case of extension lag. So if the extension, I agree with Sudeep Dai, if the extension lag is achieved by shaving the bony bump, provided the stumps are well united, it is only mal united, I'll shave off the bony bump and see the extension is achieved or not. If extension is achieved, I'll stop there. If extension is not achieved by debriding the bony bump, it has proximally migrated too much. In that case, it will not be achieved by debriding the bony bump. In that case, I'll recreate the fracture, deepen the crater, maybe shave the little bit of bony remnant from the
excess
ACL,
bone,
make it vascular,
Yes.
and then fix it.
In any condition like this, you have to do ACL reconstruction, formal ACL reconstruction, sir. Like
you see, there are a lot of studies. There are a lot of studies which.
Why ACL reconstruction? Why not the pull through suture, Amit?
I didn't say ACL reconstruction, but if you see the literature which says that along with in 30% of the cases, along with the tibial spine fracture, there is an interstitial rupture of the ACL, and these are non-functioning fibers of the ACL. So if I see that in this case, you can see a very nice ACL, normal looking ACL. If the ACL doesn't look very nice and normal, if I feel that it has been torn interstitial also, at the same time I'll do ACL reconstruction.
Okay.
Otherwise, pull out surgery. Yes.
So the ACL avulsion is very small fracture that can be missed if the eyes are not trained enough. So the consequences of ACL avulsion being missed are the non-union leading to the bony protuberance that will lead to loss of extension. Sometimes there may be non-union and sometimes there may be good union. So with this case history, are we overdoing the cases of ACL avulsion, sir? Are we overdoing the cases of ACL avulsion? Like in this case, the case was managed conservatively, and this case got away with simple debridement of the protuberance. He didn't have to undergo the pull through sutures. Are we overdoing it, Rajiv sir?
No, we're not overdoing it. We'll assess and then plan.
Okay.
So after after arthroscopy.
Overdoing what? Overdoing conservative management or overdoing surgical management?
Overdoing surgical management.
No. The thing is after. So after we do an arthroscopy and then check his extension, then I think you can plan. I mean, nobody's going to do an ACL reconstruction straight away. Everybody's going to see and treat the extension deficit.
This case got away with simple debridement of the protuberance, right?
And it depends. If that, it depends. Now, if you can get away with debriding the protuberance, well and good. If you can't, then you'll have to dig the crater and fix it there. If that is still not possible, then you might need to go in for an ACL reconstruction in that phase.
Okay.
Basically, his extension will be restored.
I still remember a case of tibial spine fracture presented to us after 5 years of injury.
Yes.
And the ACL, the bone was not in the tibial side. The bone was contracted and it was attaching into the femoral side, so it was all the way up. This kind of bone will not be pulled out down to the tibial spine, so it has to be sacrificed and do a proper ACL reconstruction.
I have seen a non-union of the ACL tibial spine, and when we did surgery and pulled it through, it healed very well. So Vivek, can we take a break?
Yes, sir. Yes.
Just 2 minutes. Yeah, you guys go on. I'll just catch you. Okay.
Okay. Sir, now the $1 million question. Why is surgery done in ACL tear? Naveen sir, how do you counsel your patients for surgery? Why you do surgery in ACL tear?
Yeah, because the ACL being one of the most important stabilizer of the knee, out of the four important ligament, this is one. And if the patient come with the torn ACL, then I will be counseling him. It's very important for your day-to-day activity, even
Okay.
your sporting activity and other things. And this is not going to heal by its own. But the way you can manage with just you modifying your activity, and which is very unlikely, maybe 5 to 10% of the cases only will going to do. So the most important thing for your rest of your life to be active life, it's better to go ahead for the surgery of ACL with the reconstruction.
So do you tell them that if ACL is not done, you will have high chance of osteoarthritis, thus leading to high chance of TKR, which is very costly surgery?
No, that is that if you see literature wise, then correlation of osteoarthritis in ACL tear, direct correlation is not there. Even the literature also doesn't suggest. But you see, ACL deficiency will lead to the meniscal tear, and in that way, the tear of the meniscus will lead to the further degeneration. And indirectly, if you see there is a chances of osteoarthritis is very high in the ACL deficient knee. So I will try to counsel him, not directly for the osteoarthritis. I will say, if you will not go for surgery, you will turn your meniscus. And then again, you will have to go for the two surgeries. So in that way, I would try to counsel the patient
Okay, Amit
and
sir, would you
convince
like
for
to add
ACL
something?
reconstruction.
Sir, I think you have to unmute it. Sir, please unmute your.
So I agree with Nabin. Yeah, I've done it. So I agree with Nabin saying that probably there is not even enough evidence to say that not doing ACL reconstruction will cause osteoarthritis. There are 10 years, 20 years, even 25 years follow-up which says that osteoarthritis in ACL reconstructed and ACL non-reconstructed knee is almost the same. But two important thing is the functional disability. If someone is having functional disability, limitation of the work, so by doing a reconstruction, this functional disability can be corrected. And then second one is the secondary injuries caused by the ACL tear. Like Naveen was trying to say that if
Yes.
his medial meniscus is torn, probably he's going to tear his middle meniscus, lateral meniscus, whatever meniscal is torn. And the association of osteoarthritis with torn meniscus is very significant. So
Yes.
it is not directly we are trying to prevent ACL, but we are trying to put them into the normal functional activities of the patient and trying to preserve the health of the meniscus, thus trying to preserve the meniscus osteoarthritis.
Okay, Sudeep sir, would you like to add something?
I think definitely I'll ask the patient like after the injury, what is hampering her day-to-day limited activities. Now,
Okay.
if the patient is not able to do the same activities after the injury, and then I'll have to convince the patient that with even somebody says I'm the copers, I'm just go to the bank, but still while climbing the steps, going down the stairs, walking, running for the buses, these are the all activities he can re-injure, he can further injure his knee. So
Do
we'll
you,
have to
sir,
give him all these conditions.
while convincing your patients, do you ever scare them with the risk of osteoarthritis and subsequent total knee replacement?
No, osteoarthritis is the very late phenomenon, I feel. It
Yes.
is the day-to-day activities that patient is not able to do, like simple activities, carrying the load, running for the buses, walking faster. I think these are the common issues that even a coopers or normal sedentary life people also will like to, they go through in day-to-day life.
Yes, I
And
think
this is how I
from the
understand.
discussion of our panelists, the ACL reconstruction does not per se prevent the risk of the osteoarthritis. There has been multiple studies that has confirmed that osteoarthritis do progress even with very well done ACLR. But why we must do ACL reconstruction is if ACL reconstruction is not done, the activity level of that patient decreases significantly, and there will be high chance of secondary injuries like meniscus and cartilage, which will ultimately lead to higher chance of osteoarthritis. These are multiple papers, and even we have published about the risk of meniscus injury after the if ACL reconstruction is delayed. And so I think ACL surgery may be a preventive surgery, and a stitch in time saves 9. That is valid for the ACL surgery as well. So risk of OA, risk of TKR, we have already talked about. And what we have found in literature is the even with ACL reconstruction, the osteoarthritis progresses, but osteoarthritis is significantly higher when ACL injury is associated with meniscus or cartilage lesion. So what we have to do with ACL reconstruction is the ACL reconstruction should be considered as a preventive surgery for the secondary injury, thus leading to decrease in the osteoarthritis. And this is another study from Taiwan, which showed that ACL injury patient, ACL injured patient and ACL injured patient with reconstruction had almost similar patterns of osteoarthritis, but the ACL reconstructed patient had very good stability in the knee joint, and the symptoms, even if in X-ray they have osteoarthritis sign, but the symptomatically they were better, and they didn't need the total knee replacement even afterward with the same level of osteoarthritis. So this was the paper from Taiwan, which gives us insight that ACL reconstruction is the best a man can get at present, even though it does not prevent the complete ACL, complete osteoarthritis. So I think this I will skip. This is my third case. I want to thank all my panelists, all my viewers for this wonderful.
Vivek, there were two questions from the floor. Can we put it for the panelists?
Please.
Regarding the ACL levels, and Dr. Devendra Acharya asked, is there any chance of contracture of ACL so that it won't fall back to the crater? And if it happens, how do you tackle the case in such scenario? You can put it to any of the panelists, or Ishwar sir, I think so, is not getting involved that much, so you can pull him also.
So Ishwar sir, would you like to answer this question, sir? Contracture of...
Yes.
Dr. Nagmani, would you like to repeat the question?
Can you repeat the question?
Yes.
Contracture in ACL levels?
Yeah. Is there any chance of contracture of ACL so that it won't fall back to the crater in case of ACL avulsion? And if it happens, how do you tackle the case in such scenario?
Well,
okay. And I'll add the other question by Dr. Sushil Thapa also regarding the same, so that you can post it to the other panelists also. What is the cutoff time limit for suture pull out in case of non-union of ACL avulsion? I mean, how long can you go out with the suture pull out as well? That might answer the first question itself.
Okay.
Also, yeah. To tell you frankly, like ACL avulsion is you have the classification of when to do a surgical pull out or repair the ACL avulsion. Type 1, where you do not have that much of a bony displacement, and you see in the MRI that the ACL is continuously aligned, you can treat it conservatively. Type 2 and type 3, where you have let's say there is a controversy, but type 3 definitely where there is total avulsion of the bony fragment. In acute cases, there is an indication for surgery. But what we are facing here is a little bit of out of normal, like it's out there in the literature also, what you do to a 3-month-old or a 6-month-old cases which has not been properly treated ACL levels. And in our experience, like if you tell me, like Abhit was saying, there have been cases where we have had cases of ACL levels and that presented after 5 years. And there are cases which are presented after 3 months or 6 months. In some cases, like the one I remember few weeks back, that there were cases which had been untreated for about 2-3 months. In those cases, we were able to reduce the fracture fragment and do a suture pull out and repair the ACL avulsion. But there were cases like the one that was already quoted by Amit, like 5 years back, there is this retraction of the bony fragment into the intercondylar notch, and you're not able to bring it back. In those cases, what we have done is we have removed the bony fragment and done a formal ACL reconstruction. So my view is that this is still not a very common thing that would come to everybody. It's just that we need to catch it early, that we should be able to differentiate, like type 1, let's treat it conservatively. Type 3, we must do a surgery and repair it on time. Whether it comes late, and the other thing was what is the cutoff time for ACL suture bridge fixation? Well, that also depends, when you do your arthroscopy and you clear out the crater and you feel that the bone is tightly fitting into the crater and you can get away with that suture bridge fixation, then that is fine and well. But if you are not able to do a total anatomic reduction of the bony fragment and then you feel there is an extension lag also, then it's better if you remove the bony fragment and do a formal ACL reconstruction.
Dr. Vivek,
Yes, sir.
regarding the, I think the question asked was whether it is possible to bring back the avulsed fragment to the crater or not. Is it so the question?
Yes.
Yeah.
Yes, yes.
Yeah, regarding the contraction of the contracture of the ligaments, I think ligament per se is not contracted.
Hmm?
And as Amit said, like in the ligament avulsion also there is some tear of the fibers, and ultimately it will be healed with fibrosis. Fibrosis will be contracted, but that can lead to some contracted of the ligament. But ligament, normal ligament per se is not contracted. It has been applicable even in the, like say in total knee replacement. If it is done in severely varus knee, it is said that the deformity is not because of the contracture of the ligaments, because ligament per se is not contracted. And
Okay.
so that contracted fibrous tissue can
I
be
want to
stretched.
add,
So
I
that
want to add, Arjun sir. Usually, I absolutely concur with Arjun sir that that ACL doesn't contract. But what happens? This fragment that is being evolved from the tibial spine, lying in the synovial fluid for very long time, so it gives a nutrition. So that fragment gets nutrition from the synovial fluid and it swells up. So the size of that fragment becomes so large that when you want to fit it that crater, that is not possible most of the time. So you have to always titrate, make a more of a crater, make a cut a part of the this. So that fixing part is difficult. Regarding the second question, till how we can go to the pull suture, if there was a BNB course, I remember Dr. Mittal projected that case. Then there was a discussion at that time. The literature even says after 2 years also, they have done a pull through suture. But the usual cutoff time he quoted at that time was 9 months. Up to 9 months, he used to do the pull through suture. Other than that, he'll go for the ACL.
I think that is basically for the healing potential of the bone of the fragment as well as the crater also.
Right.
So,
Okay, Vivek,
I
one.
okay, last question.
Yeah, Amit
Last
sir,
question before you conclude.
Amit sir
agree
was
that there
saying
should not
something.
be, yes, there should not be a detail to this. If your ACL substance is good, and then the bony fragment can be pulled to the tibial spine, you can create a crater. You can do a curated bit of osteotomy, create a crater, and put back into that crater. As Navin said, both the proximal fragment as well as the crater, proximal fragment swells up, and the crater fills up. So there is a mismatch. So you can curate, you can downside the fragment, which is attached to the ACL, and then you can fix it. Either you have to do a reconstruction or not. It depends upon how well you can bring it to the crater and how well you can fix it. You can bring it down. You can do it even after 2 years. If you cannot bring it down, probably you have to do a ACL reconstruction even after 3 months or 4 months.
Okay,
I don't have too many experiences, in these sort of cases because they come very rarely. At least to me, I've seen one. But we have done one patient, like I told you, after 3 years, and they do heal. After 3 years, I have a patient. We created a crater, freshened the graft, and they do heal. He's done well. We did a suture bridge fixation, pulled it out from both sides. He healed well.
okay.
So I think they're quite
Very true.
not
I
too
agree.
bad.
I agree.
Yeah,
I agree.
Vivek, one last question from Dr.
Okay. Okay.
Roshan
Please,
Kalwar,
please.
and then we sign up. He's asked, what do you use to fix avulsed tibial spine fractures?
Suture. Type of
I
suture.
just said, yeah.
I mean,
I
any
can-
type of
yes,
fixation, because we've been
use,
just discussing suture pull-outs. He might mean in both ways. I would request him to ask his own question in his own terms. Dr. Roshan?
Dr. Rosen? Okay, you have been unmuted.
See,
Please
if the
unmute
size
and
is
answer the
big
question.
enough, then you can go ahead with the screw. If there is a very small size communicated, then you have to go with the pull-through suture. And the common use is the fiber wire or the strong wire we use. I use fiber wire.
Okay.
Okay.
Any difference in opinion?
And he might have meant whether it's screws or anything you use any other modes of fixation, or it's just
are you talking about
sutures?
are you talking about things which were done previously? They used to do tension band, use SS wire, everything. That is in the past.
Yeah, not so sure.
Now,
Sir, but that was
I think, like Naveen said,
posted.
a big fragment, a screw. But I think I would go with suture bridge. Maybe 2 of them. Be secure enough. I think it'd be good enough. And maybe
so you don't you never use the screw, intra-articular screw, right?
I
sir?
used to use a screw previously.
No.
I used to use a sorry. I used to use a screw previously. But the screw is very difficult to target because you can't just get an angle. Yeah, it's very difficult to get that angle, the screw into that angle. So a suture bridge is great. A suture bridge is great. You create 1 or 2. Otherwise, Amit has shown a fantastic parachute technique. A parachute, right? Wonderful. That is also very good.
And how many suture strands, sir? If you are pulling it out, Dr. Bidur has asked.
You can do it from 2 sides. You can do it from 2 sides, or you can do a single one and do that parachute technique and pull it down also.
So how do you decide whether to use 1 fiber wire or 2 fiber wires, or you pull it?
Depends on your confidence. Now you're a surgeon. Depends on how you want to fix it. Your pull through and how much of strength you're going to get. It depends on that.
And depending on the size of the fragment also.
Yeah, maybe.
I mean, sir, any different ideas?
Not one suture,
Yes.
At least 4 strands. Yes.
Yeah,
tape,
double. Just double. Like a shoulder sliding knot also you use. No?
Yes.
All that. Anyway, those are technically related. Yeah.
What about tape, sir? Use of tape.
Tape I've never used. I don't know.
Yeah,
I've never used tape.
I do use tape.
Okay.
So your experience with tapes, sir, do you find any difference between sutures and tapes, or is it just the same? And it's just your preference?
It's because I feel the tape is stronger and it has a more surface area to compress it. That is my confidence.
So you've been using tapes more than the fiber wires, right, sir? Your preferred method is tapes.
Yeah.
Amit, sir, any recommendation from your side, or you? Because I've seen you
use
using
2 fiber wires, at least 2 fiber wires, at least 4 strands.
No tapes for you, sir.
Yes, I don't use tape.
Okay.
It's costly.
So the cost is the only thing, sir, or is there any difference which you have? Your preference for choosing?
Yeah, I don't find any problem with the fiber wire. So many people use fiber wires.
What problem of a stiffness with tape?
Sorry?
Arjun sir, since you've been doing tapes, have you found any stiffness? That's what Naveen sir is asking.
No, I'm not getting any stiffness.
Okay.
Because I do pull it outside, so make a knot outside with the 2 tunnels.
No stiffness from the side. That's all. Vivek,
so I think I want to thank all of the panelists again. I want to thank ASON President, ASON Vice President, and all of the participants. I think maximum we had 65 or 66 participants at a time. While it is 2.5 hours already crossed, and I think we have more than 40 participants still remaining in our chat room. It's 39. So I think our session has been great. I would like to ask Dr. Ishwar Pradhan, President of ASON, to give his closing remarks before we close up. Ishwar, sir.
Okay, guys, thank you. It was a very fruitful discussion. I hope all of you were enjoyed, and I thank Vivek for taking up the initiative and taking up this challenge and conducting this this webinar. Thank you to all the panelists also being very actively participating and sharing your knowledge and your expertise. That's one of the things we should be looking for. And it's good, we can spend 2 hours locked down, looking at friends discussing. Is one of the advantages also. Probably from next week also, Nagbani is planning for something.
No, that is something he has been scheduling. Amit sir, would you like to say something? He was planning some. So this is basically a volunteer work, sir. So anybody who is interested is picking it up.
Do you want me to pay you for that?
No.
You can. What was Nagbani planning? Was it something else? What was Nagmani planning? Was it something else? Not a webinar?
No, this time we are planning to move away from knee and actually this time we are planning to move away from knee and venture into shoulder. Probably that is one of the part that we need to learn a little bit, and then hopefully it will be on shoulder. We'll decide today and post tomorrow. So Arjun Dai, Rajiv, I'd love to be there in this thing. I'll decide today. I'll request to Chakra Pandey, Sisir Lake also to be here if they are available.
Also, yes.
Yes.
And one thing, thank you for the delegates who are not available, not visible here. I thank everybody from all over the country, getting together and making, gathering a good one. Thank you. Does Dr. Arjun want to say something?
I don't have to say many things because you have already said from as a ASON president. I also would like to thank Dr. Vivek for organizing and moderating this wonderful session, and Dr. Nagmani. He's always active in any academic activities, and our panelists from different part of the Nepal. We must say not only from Kathmandu, from different part of the Nepal, and we talk very
inclusive panels
intensively. Yeah, intensively in the from basics of ACL diagnosis, from history, what is the most useful test that is done in acute setting and chronic setting. How do you choose a patient for the ACL reconstructions and for the investigations also, and different situations we have shown that has definitely opened our eyes on managing other cases also, not only the beginner, for also to like me, who are doing the cases in our own way, because everybody is doing the case in different way, and organizing this type of webinar really helps to everybody. Thank you very much.
Okay.
Vivek.
Okay, thank you everybody. Bye.
Okay.
So wait, sir, let him say the last word.
Okay.
Okay. I would like to apologize for the technical problem in between. Apologies for
this was
sir.
Flawless.
Can
Happy
I
New Year.
say
Bye.
something
Thank
to
you
Dr.
very much.
Okay,
Bhattacharya?
Please, sir.
Happy New Year.
One sec. 1 minute. Listen. Now I think, with just one last thing. With this COVID-19, I think a lot of things have changed. So maybe Vivek done a beautiful job, a wonderful job. Last time, Amit, I missed the thing that you did. I didn't know it would be so enjoyable. Now I'll try and be present at every webinar. Okay, I think that goes for most of us. We really enjoyed the webinar. Thank you to Vivek. And I think this is, now we better get used to this, because this is what's going to happen now. A lot of things are going to change for everybody. So right from the President, Vice President, Sudeep Dai, Naveen, Nagmani, Amit, and Vivek, and all the participants. It was lovely to be here. Thank you very much for spending usefully 2 hours of this long extended lockdown. Thank you very much. Thank you very much.
No, I thank you, everybody. I just wanted to say, Dr. Arjun, you are trying to not to show your faces,
Yeah, exactly. Such slide is not.
Trying to avoid to show your faces.
Because of light. It's been anti-light.
I thought you were trying to show it many times, people avoid showing their faces.
No.
So next time.
I'm showing my face, but I am surprised to say that everybody are so smart, looking so smart. I think that
I've become whiter, sir. I've become whiter now, staying indoors. You can see that.
Not affected by the lockdown. If we see in the Facebook and other social media also, everybody is putting their photos, pictures with the beard and mustache on. But here I could not see anybody except mine. Okay, I have got some.
So I thought you didn't shave today. So that's why you got
One last
Okay, everybody. Bye. See you next Monday.
Stay home. Run.
Yeah, enjoy.
Run in the home.
Okay.
Bye.
Bye.
Happy New Year. Thank you. Bye.
Thank you.